Welcome, everybody, to the Subcommittee on the Wyoming Department of Health. As is the tradition in the Appropriations Committee, we are a subcommittee of that one. We generally begin with a prayer and a pledge, and I've asked Representative Sherwood to lead us in prayer. And Senator Larson is going to lead the pledge for us.
As we gather here today, Lord, we ask that you speak through us and
Thank you. Thank you for being here. And to those folks who are online, welcome. We hope to hear from many of you. The primary reason for this meeting was allow the committee one last opportunity to speak face to face, and we'll be doing that later on in the day with the representatives of the Department of Health and go over some ideas and be able to ask more questions and try to work toward a solution. We usually start with the concept of decorum. And quite often we brush over that. There was an incident that occurred at one of the last meetings that we had. And in that meeting, I had described a budget process. And rather than point a finger at any of the agencies here in the state or whatever, I pointed that finger at myself, said, you know, back when I was in the Army, what we did is, how much did you spend last year? How much would it cost you to do the same thing this year? And then, is there any gravy you can throw in there, any special asks to ask for? And I made a plea that we begin to rethink that method and go more to a zero-based. In other words, what are our priorities? The very first thing, the most important thing I want to do is this. What's that cost? And then prioritize it like that, with the idea that when we do come to a point where funds or resources are limited, we know where to stop. We get the important things done, and the other things that maybe we don't have to do might have to be put off for another time. So I made that case, and a certain legislator took exception to that and came into the meeting and basically said, I can assure you that never happens in Wyoming. And I, not wanting to have any kind of a scene or anything, just let that go. Okay, point taken, and passed on. And then I went and I spoke to some of the leadership in the House because, and I'll lead to a minute to make my case. I felt like that was not really the best way that this could have been handled. If we're going to accomplish anything here, we have to always be completely honest with each other. We have to be direct. And we have to take the emotion out of it and look at it as rationally as we possibly can. Very difficult to do when we're dealing with sensitive items as we are, but I believe that's what we need to do. And I think for anybody who has watched this committee operate, we have been very fair. We have tried to be as caring as possible. I have sought out as much public testimony as people are willing to give, and we'll hear from some today. But I would like to make my case just briefly, not necessarily to defend myself, but so that we all understand we've got to be honest. If this experiment is to work, and indeed any negotiation is to work, they have to be honest. We have to weigh the benefits, the wants and the needs of the taxpayer, the wants and needs of the agency, and the wants and the needs of the beneficiaries of those agencies. And only if we're honest and we have a a decent, open conversation. Can we actually get to the best solution? And that's genuinely what I'm after. So I want to take just a minute and describe for you the budget process as it happens in Wyoming. And if you go to the last, this is it, you can find it on the state budget book, or the last completed state budget book for the biennium. There's a reader's guide on page 15, and they show you a form that is used by all the agencies across the state. Column number 2 is the base budget, and the description in this book says the base budget displays the 23-24 appropriations added in to the last budget. In other words, what did we do last time? Exactly as I described. The next column says the standard budget, and the explanation for that is the amount which enables the agency to continue to furnish the same level of services during the ensuing biennium. Exactly as I described. What did you do last time? What would it cost to do it again this time? Those are the first 2 columns. The next column is a total debt exception request, total department exception request. That's where, as I've been quoted as saying, the gravy, but that's where you have your other asks and you say, okay, these are things that I would like to add to my budget. I just got one from another agency the other day, $42 million they're asking on top of what they were. Okay, we need to consider that. We need to look at those priorities. That's how this committee got here, was you guys came to us with another ask. But I think that's pretty accurately, and then the last column is the total budget request. Okay, what are you asking for? So what'd you spend last time? What would it cost to do that again? What changes do you make? And yes, you can add or subtract to that. But most often, quite frankly, we're going to add things. We very seldom go back. And then that's our total budget request. So that's how it's done in Wyoming. It was stated, I can assure you that that's not how it's done in Wyoming. If you were to go to August 20 in this very room, sitting in this very seat, there was a select committee on school facilities. And if you go to the August 20 afternoon video of that, and you set the time at 2:25 and 29 and listen to what happens. And I'm not going to play it, I could. But who the senators involved in this discussion were isn't important. They didn't do anything wrong. They just did things the way we do them. And it proves precisely what I said. One senator, they're preparing a bill. And they're saying, we've got a number of items on here that we want to ask. Let's ask for the maximum. A representative of the LSO, well, he says, let's ask for the maximum because we know that appropriations will probably cut some. It's like if you go buy a house, you start in a position and you bargain until you get there. That's how this process works. The LSO representative involved said, okay, do you mean just these numbers here or for all of these numbers over here? He said, just max them all. That's generally how we do things, is what he said. And then the chairman immediately echoes the same sentiment. Yes, that's how we've done things for years. I want us to have a very productive discussion. I want us to be open and honest and frank. What came of this was a lot of vitriol. I've gotten emails that talk about what an idiot I am because I don't even understand the budget process. That is not conducive to making Wyoming better. My goal is to make Wyoming better. That's why I'm here. That's why I gave up my retirement. I could be fly fishing. Well, maybe not in the wind, but I can. But I'm not. I'm here. And I'm here because I care. These folks beside me are here because they care. We want what's best for Wyoming. And with that, I would ask us all to be a little more cautious of how we treat each other. And thank you for allowing me that opportunity to vent. The first item on our agenda is public comment. And we generally begin with anyone in the room. And so I would like to do that. First of all, I would like to recognize Representative J.R. Riggins from here in Casper, who is here with us. Thank you for being here. Anything you would like to add to the conversation, or are you just watching? All right. Thank you for being here. And if you change your mind, decide you want to chime in, just let me know. Okay. Is there anyone else in the room who would like to offer public comment? Please come forward, fill the dais. Introduce yourself, give us your name and who you represent, and tell us what we need to hear.
Mr. Chairman, thank you. Nick Agopian. I represent the Wyoming Dental Association with members across the state, and I'm certain probably in your counties. Wanted to be here today just to offer a comment in support of the, let me make sure I use the right term, the Medicaid dental program that the state has invested in. And when I say invested, we've seen the state increase its share. I believe the Medicaid dental program, somebody will certainly correct me, is a 50-50 program where every dollar the state puts in is matched, or they split the costs associated with the program with the federal government. It's my understanding in 2024, that total cost was $15 million. And with that $15 million, they provided services to 29,323 citizens of Wyoming. That number, it appears to be down nearly a little over 1,000 individuals from 2023 to 2024. But when I say investment, I'm going back to the budget in 2023 when the state was able to utilize some of the ARPA dollars that came our way to increase the payment rates to Wyoming dentists for services provided to Medicaid patients. They increased that amount by 25% was the investment that was made at that time. And you can see how it has grown, right, from 2022 through 2024. I'm here to speak in support of those kids. And certainly on behalf of my dentists, this is dental services that these children are most likely not to be able to receive. Certainly the preventative services, emergency services always end up in a different category, I believe. But certainly this is a great opportunity for these kids this is their only opportunity, as far as I know, to get these services provided. And so that's why I'm here today, is to stand in support of that. I believe that the state has the means to continue this program and move it forward, certainly over the next budget cycle. And for that, I would stand for any questions, and certainly appreciate your time and your effort to move this forward.
Thank you for being here. I will have a comment and perhaps a question or two, but first, either of my colleagues. Senator.
Do you have an idea how that 29,000 is broken down?
Yeah, I do. So I'm going off of the Department of Health report that has a February 1, 2025. You all are probably much more familiar with this than me. Let me pull up the individuals. Medicaid dental for 2024, of that 29,300, I believe, 24,272 were individuals under the age of 20, so youth. And that's 5,078 were adults greater or older than 21. The total expenditures would be 13.35. Well, I'll use some round numbers for the children's expenditures, and 1.65 million for the adult expenditures. You know, breaking that down, I mean, it's all in front of you as well. And it ends up being, I think, per child, $550, per adult, $327. And the member rate ends up being I think $16 a month for the individuals participating.
Thank you, Mr. Chairman. Thank you, Nick, for being with us this morning. Can you speak to how this program supports the provider network in terms of the number of dentists practicing in the state? Thank you.
Certainly, it's my understanding that there are 500 providers that offer services or are registered as Medicaid providers. Certainly the children themselves, I think you see our dentists, finding time for these and scheduling these patients. I guess I'm really hesitant to sound selfish around this is $15 million that goes into our offices to help support Wyoming citizens. And so I'm really cautious that's a huge component of the revenue that comes into these offices. It's revenue that comes in at a below market rate. And unfortunately, as we look at, these children are subject to the lives that their parents live. And when these appointments, for those dentists that do accept these patients and are willing to accept that lower fee schedule, many instances, it's unfortunate that situations come up and these appointments are missed. And then we have a double impact on our offices where you have an empty appointment and you've got somebody that's been waiting for 3 months to get their teeth cleaned. In the dental offices, just like many other medical offices, something that the department ought to be commended about. I think you're going to hear about the state's application for the Rural Healthcare Transformation Plan and the efforts the state is putting forward to find healthcare workers. Our dental offices are experiencing those same situations where we don't have enough hygienists, we don't have enough techs, so it certainly could have a big impact, but the biggest impact is going to be on the futures of those kids.
I'm not happy. All right, thank you. Now, I would like to have this stated, and perhaps this question is for Director Johansson or his staff. We have the health stat report, and it lists in it for each page for each program a cost. The cost for the dental thing was 15 million plus in 24. In 23, it was 13.2. It's a 50-50 match. Does that represent just the state funds, or are there federal funds that are not reflected in those numbers? Come ahead, please. This is just for clarity, so there's never a question down the road.
Hi, Nick.
Good morning, Director.
Good morning, Mr. Chairman, members of the subcommittee, Stefan Johansson, Director for the Department of Health. Those numbers that you see would represent the total cost. And so as Nick mentioned, typically around Medicaid, we see a 50% state share, 50% federal share. The growth that you see, which Nick articulated well in this particular area, is a couple of years ago, I came to the legislature with somewhat of an emergency budget request with the Dental Association and several discussions that I had with dentists around the state, even from this community as well. We were entering a period where not only were dental providers going to stop taking new Medicaid clients, and in this case, we were really talking about children, but we had dental providers that were saying they were going to withdraw from the Medicaid program altogether. Our dental rates at that time had not been looked at, rebased, or appropriated. I believe it was over a decade. It could have been over 15 years. So we had really slid on the cost coverage side. So we had put emergency rates in place to keep coverage for the children that we were currently insuring. And then we came to the legislature and the Joint Appropriations Committee with a 25% rate increase request, which was ultimately approved. By and large, that's the result of the growth that you see there. But just remember with Medicaid, there's a few dynamics going on. So growth in total costs can often be a result from rates that are increased or decreased by the legislature, can be a result of utilization increases in certain services that you see. And also in Medicaid, as we discussed at one of our previous subcommittee meetings, there's an array of mandatory services that the federal government sets for Medicaid programs and an array of optional services that states can elect to cover. In this case, dental services are, with a few exceptions, are generally optional. And so in previous years of budget reductions, which we also went over with the subcommittee, we had significantly scaled back adult dental coverage in the Medicaid program. As Mr. Springer previously testified to you all, our interim Medicaid agent, we cover kind of the bare minimum on adult dental with cleanings and extractions. Really, the extractions are to avoid emergency department visits. So this would represent an optional service, but that's going in our health stat documents there, or if you go cross-reference the Medicaid annual report, our per member per month report, you'll see similar trends there in terms of recent growth, primarily because of a legislative direction to increase those rates.
Thank you for that. Yes, because this is not a mandated program. It's one, as I spoke to you earlier, and said it's one that we're looking at. I would say this publicly. This is near and dear to my heart. I was born here in Casper, 1962, January of 62, with a cleft lip and palate. And they panicked and they immediately said, well, we're going to send you off to the Mayo Clinic because we don't have anybody around here qualified to deal with that. Well, about a week or two after that, there was a young girl born, same situation. And a gentleman by the name of Dr. Hudgel stood up and he says, I think I could do that. And the cleft palate team started with state monies. I was their initial patient. She was number 2. And today it's one of the finest organizations in the country. So you're welcome. I say that meaning if I take this very, very seriously. I don't want to have to cut anything. But if something is mandated by the feds, and that'll lead me to a question in just a second, then we have to look at those things, So this is something that we're looking at. It's one of the programs that, is there anything in there that we need to look at? As you stated, Director, it has been attacked before because it was not there. So let's just kind of in general, I noticed one of the first things in the aging department is legal services. Legal development also has a federal mandate. What would happen if we just said we're not going to do it? How would that affect the rest of our Medicaid, sir?
Mr. Chairman, in the aging division, those are not Medicaid programs or services. That's a separate division. Those funds typically flow from a mix of federal grant funds, usually through the Older Americans Act, and some state general funds, depending on the program. And in senior programming through the senior centers, also a peppering of local match, county funds, those types of things. With legal services for the elderly or legal aid, if we chose not to do those, I think we'd have to do an analysis for the committee or the legislature on what other provisions of federal funds flowing through the Older Americans Act grant would then be impacted. Sometimes those impacts take a while to know. So in previous rounds of budget cuts, we would give estimates of federal funding or support that could be lost, and then we spend the next year and a half biennium period determining with the federal government what exactly that is. But for the programming itself, if something like what you mentioned were reduced or eliminated, essentially what that means is that elderly reaching out to that program for generally legal support with things like estates and trusts, long-term care planning, the legal guardianships, the legal items associated with aging and long-term care, community supports, those types of things would simply just not be delivered if it were eliminated, and those individuals would have to rely on something else.
So thank you. So, yeah, go ahead. How about?
Thank you, Mr. Chairman. Just a clarification on the dental. When we talk about optional services versus mandatory, is the optional just the adult coverage, or is the optional both adult and the child coverage? Thank you for your assistance.
And
Chairman, Representative Sherwood, good time for me to phone a friend so I don't say anything incorrect. It's never good when I think I know the answer to start talking, so I'll defer to Mr. Springer.
Mr.
Mr.
Chairman, I
Springer,
will-
please.
that mic does work. The red light just doesn't turn on. So it will be working when you speak.
Hello? Okay. Just keep pressing the button. Chairman Pendergraph, Representative Sherwood, for adults, the reason we were able to reduce those services because they are optional for adults to the point of reducing cleaning. And then what we were seeing is if we cut any further on adult dental, then we were actually spending more because then those actually turned into hospital visits instead of dental office visits for extraction and those light services. So the type of services that were reduced for adults were crowns, fillings, those type of things. So if somebody needs those, they need to self-pay for those right now as an adult. And at the time, the guidance was we had to apply that to all adults equally. That's evolved since those cuts were made, that there is an ability to serve different populations of adults differently. We haven't done that yet, but we have been researching it because there's been questions, for the different waivers, is there a possibility to restore the dental for the developmental disability population, for instance? So we have researched that, and other states now have been able to do that. But that was not available at the time we did that cut. We were instructed by the federal government, all adults had to be treated equally at that time. For children, and I'm really sorry because this is a horrible acronym. There's something called EPSDT, Early Periodic Screening, Detection, and Treatment. And basically for children, anything that we find that is a problem, mandatorily we have to treat. So for children, really dental is a required. And that's why in our annual report, we actually have two columns. We have a children column and an adult column, because really almost all services are mandatory for children through that pathway. So if we identify a need, we can put restrictions on it, we can set coverage limits, we can do the things that we need to do to make sure that the program is affordable, but we can't just deny treatment. So we're doing cleanings, a wide range of things for children, preventive services, but also orthodontia. So orthodontia is not covered for adults, but for children, we are doing various levels of orthodontia. It's for very severe medical impacts on their life, orthodontia. So it's a pretty high standard. So it's not for cosmetic reasons. But basically in that case, it's saying this is medically necessary because it's impacting their breathing or it's impacting their ability to chew, a number of things like that. So in that case, it's become medically necessary. So we're covering orthodontia for those reasons. And so we've been looking at all those standards, but back to the kind of crisis that came through our Health Step program, we were really seeing, and it really started with orthodontia first. We were losing orthodontists at a very rapid rate, and we're still challenged to get kids placed with orthodontists. And really we're talking about 50 to 100 kids that have very severe conditions, and we're having a hard time getting them treatment because just the rates we pay. So we've been very focused on that side, and then kind of lagging, we were seeing, oh, okay, there's 3 providers in a county, 1 has dropped out. Now the other 2 feel overwhelmed by the amount of Medicaid volume. They were all willing to do it if everybody shared equally. It's 15% of the business, but if 1 leaves, then it's 30% of the business. If the other 2 leave and 1's, then, oh my gosh, I can't do this, and then all 3 drop out. So really in Wyoming, what's worked well is that all the providers, because we do have very high Medicaid acceptance rates across almost every provider type, all the providers share the burden of serving Medicaid, because there are different things about the payment, the population. And so if that's 10 to 15% of your practice, it is more manageable. So we were seeing that with dentistry. The rates definitely help, but we also have started attending the dental conferences. We are recruiting dentists. We're actively having a team focus on that to say, we value you, we want you back, please come. So we, hopefully the dentists are feeling that. It's like a love fest, please come. So we're trying very hard to get them to come back and serve, because if we can have those preventative services happen, we're not having kids go with rotten teeth. They're not having behavioral health because their teeth hurt. They're just weird spell out effects when you have something going on with your mouth that it turns into much more expensive care.
There's a follow. You're preaching to the choir, buddy. Thank you, Mr. Springer.
Is this why you're so grumpy sometimes?
Yeah.
Yeah. Okay. Thank you, Mr. Chairman. Thank you. We lovingly pick on each other. As a follow-up to that, are we permitted in the rules to change the reimbursement rate for, say, children but not adults, or adults but not children? Or is this grouped together and the reimbursement rate has to be the same for both audiences?
Chairman Pendergraph, Representative Sherwood, we're able to pick specific codes. So there are preventive dental codes, and we can pay those codes higher. So it's not that we, for the same code, are differentiating between children and adults, but there are a number of codes that are specific to children that we could pay more. Generally, we've set most of those to be at a certain level, because most of the population at this point is children. So most of those codes are only open for children. The once a year cleaning for adults, that's obviously open for adults, but children can have more cleanings than that. They can have two a year. So that's just an example where children have 2 a year, adults have 1 a year. And then children have a much wider array of dental service available. So really those rates, those codes, many of them are only open for children. So the rate is for children, if that makes sense.
Thank you, gentlemen. I let that go a little bit unorthodox the way that was, but I let that go because we're going to be having a number of discussions over the next few weeks with the director and your staff. And I wanted the public to be able to see the type of conversation that is going to be occurring. So thank you, Mr. Agopian, for bringing that to our attention, and for you gentlemen. Yep, I see that former Representative Sweeney has joined us. Welcome, sir. Yeah. If you want to come on ahead, and then anyone else who would like to offer testimony, when a seat opens up, please come take the seat, and we'll hear what you have to say. So please introduce yourself. Tell us who you represent, and tell us what we need to hear.
Mr. Chairman, members of the committee, my name's Brandon Rosti. We're both with Representative Sweeney here, the Healthy Wyoming. We're both members of the board of directors for Healthy Wyoming. We're a nonprofit that advocates for affordable and accessible healthcare for all Wyomingites. I'm involved with health advocacy because when I was 16 years old, I was diagnosed with a rare form of skeletal muscle cancer in my foot called rhabdomyosarcoma. And because I had access to healthcare right here in my home community, my life was saved. And that's why our organization exists, is to expand and ensure that there's affordable and accessible healthcare for all Wyomingites. And our position here for this committee is that the Department of Health has duly responded to previous budget cuts with creative thinking and innovative solutions. And most of the budget goes to critical services in our communities throughout the state of Wyoming. And we don't see where the agency could make any future cuts without devastating impacts to our neediest community members. And our organization strongly opposes any cuts to the Wyoming Department of Health. In previous committee meetings, we've seen that due to the description of needs needed by the communities in Wyoming, that instead an increase in funding is needed to the agency. And especially an increase in the number of those served by the developmental disability waivers. Our organization also still supports expanding Medicaid in Wyoming to provide insurance coverage to all hardworking Wyomingites. And with that, I would thank the committee for their time and you have anything, Mr. Sweeney? Yeah.
Go ahead, sir.
So thank you, Mr. Chairman, for the time. Pat Sweeney, representing Healthy Wyoming at first, and then make some other comments and ideas and thoughts. So just to follow up on what our chairman on the board mentioned, I'd also like you to consider that our federal match, as aptly described by the chairman and the Department of Health, is 50-50. Why is that when surrounding states are in the 60 percentile? I believe Montana might be 68. I'm not exactly positive of those numbers anymore, but it's because of the wealth generated in Teton County. So how that's set, my understanding, obviously the director would have an exact description, but on the FMAP, it's represented by the overall income and then divided out across the state. So that's where we're at the lowest possible match is 50-50. So when I was in the legislature, we looked at trying to get that changed. And it literally takes an act of Congress to get that changed. So the only reason I point that out is that really puts the state and the Department of Health, in my opinion, a very bad and poor position to begin with. And it inflates, in my opinion, also the monies that we do have that you're carefully trying to consider. What inflation in general and medical inflation that we're looking at and having to deal with across the board, even with the insurance companies. So with that, I would just, my belief is if you some way could just keep the Department of Health level, don't consider cuts. I think that is cutting somewhere between 3 and 10% if you just stay level. And I don't know how you sell that to your committee members, when you take that back. But it is, Mr. Chairman, absolutely, if you stay level, it is cutting. And then I'd like to change my hat for just a second. Mr. Chairman, somebody brought up just a little bit ago about the aging division. So I would like to talk just briefly. I helped get our senior district set up. We haven't collected, well, I shouldn't say a dime yet because it takes a year to see the revenue from the property taxes. So we will shortly see our first half of the collections sometime probably in December. I bring that up because I'm also on the Meals on Wheels board here locally. And so the Division of Aging goes through the Wyoming Senior Services Board for distributing funds to, Mr. Chairman, I believe you mentioned the senior centers. And so that distribution, it's based on a formula. So our Meals on Wheels and 5 other centers across the state are going to be our Meals on Wheels. They're going to be capped out at basically 230,000, where this past fiscal year is about 565,000, and through the program. So the cap comes about, and I bring this up because this is part of the Department of Health also. The legislature, when I was there, me included, because I didn't realize the intricacies of all of these things. And we have not done a good job, the legislature has not done a good job of increasing those amounts over the years. And so that's remained basically flat. I don't know, I'm sure Director Johansson and his team could give you an exact amount. But we're working on trying to fix the formula with the cap. The reason that has changed is over time, more citizens and the elderly, myself included, have asked for more services in their communities and set up more senior centers or more Meals on Wheels programs. Yes, we do local fundraising. The senior district will help. But because of property taxes reduction, I can give you a pretty close number. That decreased our collections here in Natrona County for the new senior district an estimated 300,000 to 400,000 because of the property tax reductions in different iterations, all put together. And that's, again, just estimated because things are still in flux. So when I say about the inflation, medical inflation, that's why I'm saying, you know, if you can maintain in these times, if you can maintain, you are accomplishing cuts. Lastly, I would just like to say, when you're looking in the legislature at all, for all the legislature, I believe the other thing to consider is stop monkeying with the property tax. Delve just directly. My belief is we started all of this in particular to keep people in their homes. So how do we get that done? My best advice is continue the long-term homeowner policies. You know, it's got an age restriction. It's got some other pieces to it. You've got to have paid taxes, property tax for X amount of years. Continue that program. That's very important to our citizens to keep them in their homes. And we've got a ballot measure coming up in 26 that could possibly be totally devastating at 50%, which I don't agree with. But so did I come with a solution? Possibly, but I know it's not very popular. But thank you, Mr. Chairman.
Thank you, Mr. Sweeney, for your comments. I do understand what you're saying about if you keep it flat. That essentially is what has happened to the Department of Transportation over the last 20-some years, is they've been flat. Meanwhile, the Department of Health has gone up exponentially. Now, the last few years, and I have those numbers, we'll discuss those. The last few years, it has leveled off considerably until the last couple. But we'll get into all of those. And I will have some comments at the close, just comments in general for the public that address some of what you brought up about, you know, the increases over the years and where we are as a state. It will also include some remarks about the Craig report that recently came out, and frankly, it was a bit of a relief. It looked a little better. So, thank you for your comments. No, any further questions? Okay, anyone else, please? Again, introduce yourself and who you represent and tell us what we need to hear.
Good morning, Mr. Chairman, Senator Larson, Representative Sherwood. My name is Eric Nelson, and I would like to thank you for the opportunity to address the subcommittee this morning regarding behavioral health funding. By way of background, I wear a number of hats which involve me in the behavioral health sphere. I am currently the chair of the Natrona Collective Health Trust, a private foundation which has identified behavioral health as the #1 health priority in our county. I'm also a current board member of Central Wyoming Counseling Center, our community mental health center, and I'm joined by members of both those boards here today. Finally, I am employed as the Casper City Attorney, and this is the capacity which I appear before you today. And former Representative Sweeney happens to be one of my bosses, so please be kind. While the topic of behavioral health funding is complex and can fill numerous days of testimony and discussion, I wanted to address one concern which has been voiced in previous meetings of the subcommittee. Specifically, how do we know whether behavioral health services are working? And what I want to do is walk you through a diversion court program that we have started through the Casper Municipal Court. We've had this program in effect for about a year, and it could not operate without Central Wyoming Counseling Center, which in turn could not operate without the funding it receives from the Department of Health. Now, as city attorney, my office is responsible for prosecuting ordinance violations. We handle in excess of 10,000 citations a year. While the majority of these cases involve traffic issues, we also handle citations involving public intoxication, public disturbance, DUI, and other nonviolent substance abuse related charges. Many of these individuals are suffering from mental health issues. And as a municipal court, if competency is raised as an issue, the state hospital does not perform that examination. So we're kind of at an impasse. Working with our police department and other community stakeholders, we've identified what we refer to as MVPs, or most visible persons. These are individuals who are the most frequent users of city services, such as police, fire, and EMS services. I can tell you personally that we have individuals who are arrested multiple times a week for public intoxication, camping in the city, causing disturbances downtown, affecting our businesses, affecting our citizens. As a fine-only court, these individuals rack up enormous amounts of fines, and when they eventually cannot or do not pay, they're held in contempt and jailed until they are released, and we start the process all over again. The city pays $147 a day to jail these folks, and with really no end in sight. So in 2024, my office, in conjunction with the Casper Municipal Court, the Wyoming Supreme Court, and CWCC, began a substance abuse and mental health diversion program. This program allows individuals to seek treatment for their mental health problems, be they mental health or substance abuse, and receive credits against their fines. Gets a little more complicated than that, but it's probably beyond the scope of my testimony this morning. But I would say this program has been very successful, and it would not be possible without Central Wyoming Counseling Center and the funding it receives from the Department of Health. We've attempted over the last year to compile data. And I can tell you from October 1st, 2024 through November 5th, 2025, through this program, we've had 91 enrollments into the residential treatment program at Central Wyoming Counseling Center, 60 enrollments in the chemical dependency unit, 56 enrollments into the crisis stabilization center. These individuals are either formally released to CWCC as diversion placements, or individuals who have been sentenced and received fines can go and work off their fines, essentially getting $30 a day credit for their participation in treatment. We've had 10 successfully graduate residential treatment. 4 of those have actually gone through the process twice. And just like any other medical care, it's not a linear process towards sobriety. It often takes a couple of bites at the apple. We have 2 currently enrolled, and there have been some that have dropped out, and then we deal with them back in the court. But what this shows is that this resource is being utilized. This population, which is targeted with behavioral health reform, is being served in a capacity that hasn't been seen previously. In talking to the municipal court for the city of Casper, I can tell you that we've saved jail costs in the approximate amount of $349,272. And when I say saved, those are days that we would have incarcerated somebody, but they've been in treatment. Other costs, taxpayer costs that we've avoided include fewer police calls, fewer fire and EMS time, wear and tear on equipment, court and staff time. Every time an individual, there's a call because they're intoxicated downtown, typically it's 2 police units, it's an ambulance, it's a fire truck. And so what we've seen is after these folks have gone to Central and received treatment, the recidivism is down substantially. Many of these graduates are not reoffending. And so when you go from 3 to 4 calls a week to 0. That's a huge savings for the taxpayer, for the city, as well as getting these folks back to productive lives. And so what are the broader implications for Wyoming? Obviously, it reduces jail utilization. It breaks that cycle of dependence on those city and local services. It's improved public safety. Those who complete treatment are exhibiting greater stability and are less likely to reoffend. These folks are back into the workforce. They're earning salaries, getting job training, reconnecting with family systems. And I'm proud to say that our community here has a great number of stakeholders who have come together. Just here the last 3 days, we had a summit where we had dozens of stakeholders come together to address these issues. And it really goes to show the value of our community mental health center. And so this is all supported by national research around these types of programs. So in summation, Mr. Chairman, members of the committee, I think in just this 1 year snippet, we have shown that upfront behavioral health interventions not only help our citizens to return to productive and fulfilling lives, but offer a tangible return on investment. This upfront investment through funding for our community mental health centers is much less than the cost of having to deal with the recidivism on the back end. And so this is a benefit to taxpayers. And in my 25 years in living in Wyoming, we like to be pragmatic and we like to do the right thing and save money. And I think this is one of those rare instances where it does both. So without our community mental health center, which relies on this funding from the state, none of these efforts would be possible. And so I would just urge you as you enter into the budget session and you have these discussions to please keep this in mind. And with that, I would thank you for your time and certainly happy to try to answer any questions you might have.
Thank you. Question? Go ahead.
Thank you, Mr. Chairman. Is this pilot program expanding to any other communities in our state?
Thank you, Mr. Chairman. Representative Sherwood. Yes. And so the formal diversion program was piloted in Campbell County through the circuit court. We also have it in circuit court here in Natrona County. What our experience over the last year is that the municipal court, because it's outside of the state judicial system and is a local construct, we have greater flexibility. And frankly, it's the court where people are going to interact with us the most. And so I had conversations with Justice Fenn and Kurt Zunker from the Supreme Court, and we are going to invite folks from Cheyenne, the city of Cheyenne up to shadow us and work with them to hopefully stand up a similar program in Laramie County based on the results we're seeing. And again, we're just a year into it. And so we're continuing to refine this and improve it. Frankly, I'm very proud of it. It's my office that's at the center of it, but it's my employees that are doing the bulk of the work and the folks up at Central Wyoming Counseling Center. I give a shout out to Jackie Brown, who's now a judge in Platte County. She was my prosecutor that really spearheaded this. So again, yes, we hope to replicate this throughout the state and to realize even greater cost savings on a statewide level.
Thank you, Mr. Nelson. Any questions, Senator Larson? Okay. Thank you for bringing this to our attention. I appreciate the letter.
Yeah.
It is helpful. And before you leave, Ms. Martineau, I know that we have Elisa Butler there. She wasn't planning on testifying, but ma'am, if there's anything you would like to add to this discussion, this might be a good time to interject it.
Good morning, Mr. Chairman. Can you see and hear me?
We can. Thank you for being here with us. And I just wanted to offer you an opportunity to weigh in on this topic.
Mr. Chairman, I don't think I have anything to add. I just wanted to make sure that I was available in case there were any questions from the subcommittee.
All right, that was my understanding, but I want to be as forthcoming as we possibly can. Thank you for being there. And if you have to add anything, please don't hesitate to jump up there.
Thank you, Mr. Chairman. I appreciate it.
Thank you, Mr. Chairman.
Thank you, sir. Anyone else in the room? Please come forward. You know the routine. Introduce yourself, who you represent. Tell us what we need to hear.
I'm the clinical director for our diversion programs at Central Wyoming Counseling Center. And I thank you for the opportunity to speak with you this morning. We partner with our local and state criminal justice systems to provide alternatives to incarceration. Over the past year, we've seen firsthand impact of how those programs can work in our communities, as well as those that are in other areas of the state. What this tells us, the overwhelming successes that we've seen in these programs is that when treatment is available, people choose recovery. During this time, we've had people enter into all various levels of care with Central Wyoming Counseling Center and other providers around the community. And most of them, the overwhelming majority of the people that have been diverted have completed those programs. This tells us that there are individuals returning to their families, their jobs, and their communities. We also know from national research that these programs work in other parts of our great country. The outcomes we're seeing here in Wyoming mirror those findings. When we invest in treatment, we reduce jail overcrowding, we offset the cost of incarceration, we strengthen our workforce, and we increase community safety. Cuts to these behavioral health fundings would not simply reduce services, they would reduce options. They would mean more people remaining in custody instead of receiving the care that allows them to stabilize and succeed. The question before us is not just financial, it's about what kind of outcomes we want to see for the people of Wyoming. Diversion works, treatment works, and maintaining these programs is an investment in healthier families, safer neighborhoods, and a stronger Wyoming. Thank you.
Well put, Mr. Merrick. Questions, Senator? Representative? I'd have the question, this Central Wyoming Counseling Center, does it do youth as well as adults, or what's the makeup there?
We do. We are in the beginnings of our adolescent diversion program. We have a full-time employee that's dedicated to helping build that program. with our local stakeholders.
Thank you. Seeing no further questions, thank you for being here.
Thank you, sir. And thank you for your service.
Thank you. Anyone else? Don't be shy. We want to hear from you. That's why I drove all the way down here. Come on up, sir. Once again, let us know who you are, who you represent, what we need to know.
Mr. Chairman, members of the subcommittee, good morning. Thank you for allowing me to appear before you. My name is John Harlan. I'm the Natrona County Sheriff, and I've been employed at the Sheriff's Office for 28 years. So it's good to see you today. I think as a fellow elected official, it's incumbent on all of us to be very watchful of the public's dollars. I appreciate your service. I appreciate the attention that you're giving to this topic. So I can tell you I didn't plan on testifying today, but it's good to see Senator Larson. If I remember right, we toured our jail together and had some lengthy conversation on what happens behind those walls. So in Natrona County, we do operate the largest jail in Wyoming. We have a bed capacity of 476. And we have a lot of exposure every day, day and night, to mental health crisis and behavioral health crisis. And we're actually making some progress, I think, in Wyoming on those topics. Of course, the desire is to pull people out of the system that don't need to be incarcerated. It's expensive to incarcerate people. There certainly are people in the world that should not be free in society, and that's where our efforts need to be focused. There is a considerable amount of people that are involved in the criminal justice system for mere fact that they are suffering from mental health crisis or behavioral health crisis, and that results in codependencies with drugs and alcohol and the behaviors that come along with all those addictions. So I guess what I'd like to impose on you is that unfortunately the mental health crisis and behavioral health crisis, regardless of our best efforts, we cannot legislate that away. It is a topic that requires investment, not only of a financial sense, but an effort sense. And I think that we are very fortunate in Wyoming that we care about our fellow man and our community members, and we have that investment of effort and time. People volunteer towards those goals, and it does require all of us to bind together and provide some type of financial investment. And I will tell you, I do believe, honestly, I believe that there's a return on that investment. When we pull those people out of the system, they return to our communities. Those folks want to be productive members of the community. They want to contribute. They're our neighbors, our family members, our friends, and we should provide them that assistance. It's possible. I've seen it. I know people that have been in crisis. With help, they have come out of crisis, and they're great people. They really are. And they're doing good things. But this is a real problem. I understand that there are efficiencies and inefficiencies in government, and I think we all need to have a watchful eye to look for those and try to improve and be responsible with the taxpayers' dollars that we're entrusted with. Mental health and behavioral health is one of those issues that, if not funded, the problem does not go away. It only gets worse and continues to get worse because there's no solution at the end. So I guess I share that with you. I apologize I didn't provide data. I'm sure you have plenty of it to review. I just wanted to give you a heartfelt insight real quick on my viewpoint. Since I do have boots on the ground every day for a long time, my staff would share the same message with you. And thank you, Senator Larson, for taking the time to get your hands dirty and invest yourself in walking through our facility and hearing those stories and seeing those sites. And I would certainly open that invitation to the rest of the subcommittee or any of your fellow legislators. You're always welcome. We can have those conversations. You can actually see what it looks like. You can see some of the programs working. I'd be happy to let you have conversations with anybody in our facility. They can tell you what it looks like, what they need, what they're looking for, and the little hand up that they need to change the lifestyle and become contributing members again. Thank you, Mr. Chairman. I stand for your questions.
Thank you, Sheriff Harlan, for being here. I will have a couple of questions myself, but first, Senator, any questions, comments?
Mr. Chairman, thank you. I don't really have any questions. I just did learn a lot in that tour, and I should go do it again.
Mr. Chairman, Senator Larson, thank you.
Representative, you happy? Have you ever toured the jail? I did. So, a couple of things. Representative, aren't you the liaison with Department of Corrections? Or is that Scott Smith? Okay, Representative. I bring that up because I've been intimately involved with the boys' school in Worland, toured that facility several times, spoken at length to people that are there. And yes, we have some problems. How we address those is something that I'm acutely interested in, as well as the topic at hand. And so I appreciate your coming forward, and I would be glad to talk with you aside at length. You talked about the program that you're doing here and its dependency on these funds, and no doubt that's true. Are there any, for example, any faith-based organizations, or do you get help from any other organizations out there?
Mr. Chairman, thank you for the question. We're actually very fortunate, probably as you've heard in other testimony here in Natrona County, we have a fantastic group of resources, and some of those are government, some are private, some are volunteer, and we have all come together and formed a collective group that sits down and works through the problems. We've actually engaged in the SIM modeling, so we've mapped out the entire journey that somebody takes through a criminal justice system. We've strategically looked for any gaps in service or where other people can provide services. So it is a very diverse idea of providing service to somebody. So all the funding does not come from the Department of Health. We have philanthropic organizations that provide money and funding. We have volunteer organizations that cover their own costs. My budget is very small for the programs that we have inside the detention center because we have those community partners come in and provide those services. We do have quite a few faith-based organizations that are involved in that collective effort. The nice thing is when we all get together, and I think the vision is the same for any community, when we all come together as Wyomingites, we all have different authorities, we have different resources available, we have different funding streams, and in a process where you kind of lay out the entire need, everybody can raise their hand and say, I can help there, I can help over here, and it's really working. And I guess my thought is, my request is, things are going okay. We're seeing successes, and we don't want to disrupt that. And the Department of Health has been a vital partner in that effort. We are working on a lot of different fronts. I have regular conversations with the director himself. He's made himself available. He's thinking outside the box. He's attentive to the needs and concerns of sheriffs as we manage the inmate population in the jail. And we try to move inmates through the criminal justice process, and good things are happening. So I think if there is some way that we can avoid disruption to that, then we won't be set back in that process. And again, the goal is just to restore our citizens, our family, friends, and neighbors back to contributing members in our communities. And that's where they want to be. And we're really not even talking about an identifiable segment of our communities. It's not those people. We have people in our jail from all walks of life, bank accounts of all different sizes, and a lot of people just need to refocus, and they need a little help, and they get back to being contributing members. And that's what we want.
Go ahead, Senator.
Mr. Chairman, thank you. Do you see your program being used or a similar type throughout the state? And if not, do you discuss this at the Sheriff Association meetings and such?
Mr. Chairman, Senator Larson, thank you. I do think, we are fortunate in Trona County to have quite a few resources just based on our population size. But a lot of these programs are scalable. I certainly think they are. We have just fantastic citizens across the state of Wyoming, and everybody in time of need will raise their hand and say, how can I help? So when there's a need presented, the community can get together and say, this is how I can help. And then their neighbor says, this is how I can help. There are mental health professionals, there are behavioral health professionals in different capacities throughout Wyoming. So the availability to have something similar to what we're doing work is certainly possible. It's just scalable like anything else in Wyoming is.
Follow up? Okay. You done?
Thank you, Mr. Chairman. Just a comment. One, I know that coming in front of us sometimes can be, a nervous exercise, but so thank you so much for using your voice to help educate us about these public-private partnerships. I think it just serves as a really great reminder of how state government has a role at the table in the ecosystem and providing services, but really wanted to thank you for your service in this community.
Mr. Chairman, Representative Sherwood, thank you very much.
Thank you for being here and for bringing us. I'm sure that we'll be talking more in the near future. I just want to speak very briefly to anyone who may be watching this. I think one of the problems that we've had in the past is, why should I go get involved? Why should I put out the effort, whether I'm interested in being a part of a philanthropic organization or faith-based? Well, that's what we got government for. They'll do it, And we do have a tendency to think that's what I pay taxes for, they'll handle it. And I think that's the wrong answer for everybody. And a lot of you are very active, and I commend you guys for being involved in these organizations and the help that's out there. I would encourage anyone within the sound of my voice, seriously consider that, especially you faith-based organizations. As a fellow pastor, this is our responsibility, especially when you talk about behavioral health and all of these things. This is, God put us here as a spiritual help, and we can't shirk that responsibility. So just because there is a government program, don't depend on that. And I would use the SNAP program as an example of the problem. If you put yourself in a position where you're dependent upon that, and I understand how you get there, but politics is fickle, and the whim of governments comes and goes, and it comes right down to what is the proper role of government, and those are things we have to think long and hard about. It's been really easy just to push it off, let somebody else do it. I think those days are behind us. So thank you for your involvement. Thank you for your service to the Sheriff's Department and to Trona County. and for being here today.
Thank you, Mr. Chairman.
You bet. Please come forward. Thank you all for being willing to come and talk to us.
Go first, Anna.
Go ahead.
Good morning. My name is Pam Brondis. I'm also a member of Central Wyoming Counseling Center, but I'm going to address you in the capacity as a board member of the Foundation for the Episcopal Diocese of Wyoming, as well as a member of St. Mark's Episcopal Church. And specifically, I'd like to address the faith-based comments that you brought up. Central Wyoming Counseling Center has entered into a really interesting partnership with St. Mark's Church here in Casper, Wyoming, where we provide meals for individuals that are graduating from residential treatment. It's really their first opportunity outside of the treatment facility to be in outside of that facility. And some of these individuals have been there from 3 months to 9 months. They work with a chef that is an individual of our parish, and they create a meal, and their family members and individuals from different rehab organizations within Casper come and share a meal together. It's an opportunity for them to reconnect with their families that they haven't seen for an extended period of time. It's an opportunity for them to get mentorship from other individuals within Casper, where they can then assimilate back into our community. And it's just it's been a very, very positive experience. So St. Mark's has funded that. The Episcopal Foundation of Wyoming has offered some funds, and we work in conjunction with CWCC. And we're actually looking at how we can scale this and use it throughout the state of Wyoming. So again, that's a different creative partnership. We wouldn't be able to do this without CWCC. We wouldn't be able to do this without the staff of CWCC that has to be there with the clients. So that is an example. Another example is Soul Shop, which is specific faith-based training in how to deal with suicide prevention within religious organizations throughout the state. Initially, CWCC was coming in and helping us with putting those programs on, offering resources. So again, a great partnership. And then this is an organization, it's run by the Episcopal Church, but it is offered to all denominations within the state of Wyoming. We've had Catholic priests, we've had Protestant priests, we've had individuals throughout the state and different faith-based organizations coming in and being involved in that. I guess I do appreciate that your comments in relation to SNAP, Representative Pendergraft. One of the things that we've come across is, like every religious organizations, there's so much need, and we can only meet certain, we're spread thin too. So we have to partnership with the government. I think I'm coming from, we need to serve our individuals as, just in the model that Christ set for us. We need to walk in that manner. But we really do have limited resources. So I think there is a definite role for the government, and there's a definite role as individuals and followers of Christ to meet those needs. So just in that perspective, we have to walk forward together in that. So thank you very much.
Thank you for those comments. Questions? No questions. All right, thank you. Ma'am?
Good morning. My name is Anna Kinder. I am the director of the Casper and Nechona County Health Department. I had the opportunity to speak to you before. Had not planned to speak today, but feel that I have a piece of some items that were previously discussed. Stressing how important the support of the Health Department of Health at the state level is, where it trickles down to the local level. It gives us the opportunity to care for those we live and work and play with. And our concern, as I noted before, is population health, and we're looking to make that difference in both mental and physical health. So at our local level, our county commissioners have vested in the public health department and building a state-of-the-art new health department that will be opening tentatively February 4th. Efficiencies on the work level, those that we can serve, safety and protection, basically have the ability to adapt to whatever presents itself. I invite you, if you ever have the opportunity, for a tour of the building to see what we've considered as we've moved forward in those last couple of years. But it's important to note that they recognize that the public's health is extremely important to where we are. We do participate in what the previous speakers have talked about. So as a health department working with fire, police, corrections, all of those other areas has been a unique opportunity. We do go into the jail and we provide education for specific groups of individuals on healthy relationships, communicable and preventative diseases, helping them give skills for success in once they are discharged from the jail. So there is a variety of things that we do. We're constantly looking to see where we can make a difference. We're not just the run-of-the-mill, always thinking outside of the box of how we can help improve the health of our citizens. So I basically just wanted to say that, you know, we are creative in looking for ways to make a difference. And so that is a perfect example of one area. And then to invite you to our building to see the other things that we provide. So I thank you for this opportunity. And if you have any questions, I'd be happy to answer them.
Mr. Chairman, thank you. Thank you for being here and coming forward. You mentioned that you are helping those that have come out of incarceration, and is that a one-time deal, or do you kind of do that over a couple weeks or a couple months?
Thank you for that question, Mr. Chairman and Senator Larson. Actually, this is a program that has been evolving. I was involved since 2021 when we first started having the first sequential intercept model, the SIM project that we've been doing. And now we've just completed our second one in the previous last 3 days. So as we've been moving forward, we've been going in and providing those services in the jail, doing a lot of education and training and testing, providing those resources. We also go to the CRC. We go into the Central Wyoming Counseling Center, providing those same education opportunities. We stand available for people if they come in and require services, but through our partners, we're also going out into other areas, downtown outreach, if we need to intercept people who may have gone back to the streets, helping connecting them to services. So it's a constant evolving, changing how we provide services, but basically that prevention and trying to connect them to what they need to.
Thank you for being here. And if you would please leave a card or a contact information with LSO, I would like to talk to you.
Okay, perfect. Thank you.
Yep, thank you. Anybody else? Oh, no, we can't give you 2 turns. You've been term limited out.
Maybe he's got a different hat on.
He probably does. So, sir.
Thank you, Mr. Chairman, for another bite at the apple. Totally spaced. I believe you're going to hear from the director on the Rural Health Transformation Program next. I just wanted to briefly say, and I missed it, I apologize, but totally in support. And I think the department deserves a lot of credit in trying to get this put together in such a short window, and hopefully it'll produce great results. It's not all we can, rely on, and Anna does such a great job at our Department of Health. And I just would add on the infrastructure bill. There was part of that was set aside for healthcare. And unfortunately, Natrona County had applied towards this new building for $10 million. And it got whittled down to, I think it was 4.5 right around there, which kind of set that project back a little bit on funding, but our county commissioners put forward that. I'm only saying that because I believe this will be used differently. That was kind of a backfill left over from the pandemic. But this facility is remarkable and provides for the future of Natrona County and central Wyoming, because we do see some overlap a little bit from other counties in services, but just appreciate the second bite of the apple. Thank you, Mr. Chairman.
Thank you. Thank you for your service to the state. I know what that's like. Anybody else? Seeing none, let's move to online. Do we have any elected officials online who would care to comment?
Mr. Chairman, if there is anyone online who would like to provide public comment, please raise your hand in Zoom so we can acknowledge you. Thank you. Mr. Chairman, we have 2 individuals, but they are not elected officials. Would you entertain
Okay.
other public comment?
Yes, go ahead. We there? Welcome, sir. Please introduce yourself and tell us what we need to hear.
Good morning. Thank you, Mr. Chairman. My name is Nathan Cook. I'm up in Park County. I wear a couple different hats. One, I'm the owner of Chrysalis Treatment Center, a residential treatment center. We work with adolescents with addiction issues. But I'm coming before you today. I've been asked to give my experience as an owner of a business here in Wyoming regarding adults with developmental disabilities and acquired brain injury. And I've been asked to kind of give my experience the last few years and where we're at with funding. So I started in this industry in 2011. Gone to this program. We started up working with adults with developmental disabilities and acquired brain injury. We started up programs such as equine programs with these folks, woodworking, hunting, photography, etc. We even started a thrift store where we can teach our folks that we work with the job skills that might transfer out into the community. The extra money that we'd make would go toward activities that we could help them with. Over the years after that, we worked up to about 40 to 50 participants that we worked with. Opened up a second location in the state of Wyoming. In 2020, I went back last night, at the same time this year in 2020, we employed 48 employees in Wyoming. Obviously COVID hit, but we kept going. But more than that, with COVID and the inflation, it made things very, very difficult. Very difficult. In 2022, ARPA funding was utilized to help in this area. And I should back up a little bit. In 2021, there was a survey done and showed that we were grossly underfunded at that time. Now increase with COVID and inflation, it was even more difficult. With ARPA funding, we were required to use that money, if we accepted it, to go toward our direct care staff, toward wages and whatnot. That was a requirement for that funding. When we got on the phone call with the state of Wyoming and asked them, with kind of a question and answer session, we asked them specifically if the funding would be there after a couple of years when it was supposed to be ending. And at that time, they said they didn't know if funding would still be there or not. And then my follow-up question was, it felt like we were kind of being set up to fail because we had to use that funding toward staffing. which was good. But when they pulled the money out, which we all figured they would, that increase in pay, we could not take that back, or else obviously we lose all of our staffing and wouldn't be able to run our programs. And that's what happened in September of this year. That funding was terminated, resulting in tens of thousands of dollars a month being lost. Since 2020, we went from between 40 to 50 participants that we worked with daily, to where we had a cut last month down to 19 participants because we didn't have the funding to continue working with those other participants. We went from 48 employees to where we recently cut down to 20. It's been increasingly difficult. I'm not going to say impossible, but it's getting close to that to continue providing services in the state of Wyoming as we continue to lose funding and the increase in inflation. Really, I didn't want to take too much time. I just want to keep it short. That's been our experience. I'm hoping that funds can be looked at. Like I said, especially with that 2021 survey where it showed that we were significantly underfunded before that inflation really started hitting hard. And then, of course, with whether we want to call it a cut or just the money was no longer there, I'm sorry, on September 1st, it just has made it very, very difficult.
Thank you, Mr. Cook. Any questions from the committee? Go ahead, Senator.
Not a real question, just thank you for being online, and it was great visiting with you last night, and we hear you, so thanks.
Thank you. And we look forward to your visit, sir, next week.
Thank you, Mr. Cook, for being here, and thank you for all that you do.
Thank you, sir. Mr. Chairman.
Next.
Mr. Chairman, my name is Kevin Lewis. I'm a resident of Laramie County. I don't really represent anybody but myself, and actually I'm kind of here to help. With regards to representatives speaking before citizens, I would like to mention that Representative Steve Johnson is sitting right next to me here.
Thank you, Mr. Chairman and the committee. I'm glad to be here today and have some questions to ask.
Please proceed.
Go ahead, Kevin. Let you get started.
Mr. Chairman, Representative Johnson asked me to go ahead and get started. Last night, he had come by my house and asked about how you would actually go through and look at an agency like Department of Health. And so we sat down, we opened up a website that was started by our illustrious state auditor, Christy Racinez, wyopen.gov, and downloaded 933,705, which should make her happy, transactions of the Department of Health since January 1st of 2024. So that goes through November 5th of 2025 and is the current biennium for a total of $1.475 billion. And we would like to report on that a little bit and get back to exactly what you spoke about when you vented earlier today. Where are we spending the money now? And that's where budgets normally start. And I really appreciate that venting because it's a perfect lead into what we're talking about. We ran a bunch of statistics, and I'm more than happy to share those with the committee. I haven't been able to do that. I don't have an email to share with LSO. It wasn't on the website. In fact, it was actually rather hard to find you on the website. In our case, we went ahead and calculated the total amount of money spent. That will exclude some confidential expenses, but the vast majority of money is $1.475 billion. In the state of Wyoming, the Wyoming Department of Health spends about $1,033,000,000 of that 1.45, or 69.9%, is spent in the state of Wyoming. The second most state is 60 million in California, 50 million in Pennsylvania, and then so forth down the list. So 70% in Wyoming is a fairly good number. If you count the confidential ones, it probably goes higher. Not a lot, but a little bit. We looked at the expenditures per category, and the number one category that Department of Health spends on is client recipients and benefits paid, which is makes entire sense. 78% of their budget goes in that direction. Okay. We looked at the vendors. There are 240 vendors, probably all receiving contracts or grants or both. The $240 million vendors, there's actually about 4,300 vendors in the list. It's quite revealing. The largest vendor carries 4.7% of the spending of the Department of Health. That would be the Wind River Family and Community Healthcare, and that's an interesting deal. And there's far more where that comes from. It's really a helpful spreadsheet to look at when you're actually talking to people. You can see where money is being spent and when they're testifying how much they've been spent on in the Department of Health. It's very interesting at all. I will let you go, and if you have questions for me, I'm more than happy to answer them. I do plan to attend your next meeting and give you even more statistics from where we stand today as of November 5th.
Thank you. And obviously, Mr. Lewis, I would be interested in seeing what you have produced. And so I would trust that we can get some sort of connection with him so that he can make that.
Absolutely, Mr. Chairman, I will send them to you. And I will try to get them to the LSO as well.
Yeah, please do. Thank you for being here. Any questions of Mr. Lewis? No questions being seen. Representative Johnson, welcome. It's good to see you, sir.
Thank you, Mr. Chairman. I'm glad to be here today. And we just finished up last week with our Corporations Committee, and we had a bill on public funds lobbying groups. And what was really interesting was that Wyoming Hospital Association has been given about $69 million of state funds, and we'd like to see the contract and where that money is going. This biennium, they've spent about $831,000 in just this current biennium. We'd like to see where it's going. You know, my constituents are worried about public spending and what it's being spent on. And if we're giving a lobbying group money to lobby us, it's kind of disconcerting. We want to know, first of all, they're not elected like we are, but they have the ability to try and sway public opinion. And so we would like to see the contracts and see where that money is being spent. And of course, we haven't had time to look that up, you know, in a couple of days, but we're sure looking forward to showing you where their money is being spent.
Thank you, Representative. And I would say to the public, this has been a concern of a lot of us. Public monies going to lobbying organizations, something that we are planning to look into and to try to sort out. And I'll just leave that at there. Any questions from the committee? Senator Larson.
Mr. Chairman, I don't know. I see the director is kind of nodding his head at times and wondered if he may want to comment. I don't know if you can do that.
By all means, I want this to be a back and forth conversation and keep it open, unless you disagree with me. And then, of course, I'll get with you right down.
Mr. Chairman, be careful giving me that opportunity to reject that request. But no, absolutely happy to comment on that and appreciate Representative Johnson and the testimony here on looking at, it's a very good site that the State Auditor's Office put together to see where the funds are going. Specific to the last point raised where the Hospital Association receives funding from the Department of Health, I'll give you a few examples. Generally, before I do that, we are absolutely prohibited from lobbying ourselves or engaging in grassroots lobbying. We take that very seriously. The Hospital Association, as an example, acts as a fiscal pass-through or fiscal agent on a number of funding items over the years that the Department of Health receives. For example, things like our flex grants that come from the federal government that go out to hospitals. We use the Hospital Association as, kind of a singular entity to avoid, numerous or dozens of contracts, that duplication of effort, et cetera, in programs like that. The flex grant, the SHIP grant, there's a few, and we're happy. All of those contracts are public. So to the points that were just made, we operate a full public records request process in the Department of Health, but often if folks are requesting a contract, we'll share that without the need to go through a public records request process. Secondly, I'll mention that from about 2020 to 2024, during the pandemic, when a lot of federal funds were flowing into the state, we had some significant emergency situations like staffing at hospitals, nursing facilities, assisted living facilities, DD providers, et cetera. And we made the decision, this was resulted in legislative discussion as well, to provide emergency funding relief during those times to those types of providers. We used at a pretty high scale, which I don't know, I haven't seen the data that's being referenced, but would assume that some of those larger amounts are likely related to that time period because we used the Hospital Association again as a more efficient way to get dollars out the door. But I think it's worth mentioning that we do not fund lobbying activities, and if there's concern that we do that, we are more than happy to discuss those concerns and provide contracts and statements of work and those types of things.
Thank you, Director. Mr. Lewis, I believe you said that you had gone back through 2024. Is that correct? The numbers that you were looking at?
Yeah, last night we went back to July 1st, 2024.
Okay, in light of that, Director, is that still a carryover from the funds that you're talking about, or it seems to me there ought to be a little separation there, but.
Mr. Chairman, it very well could be. Again, we'd have to see the data that's being referenced, and happy to do that. And both currently and historic provide that type of information or contracts.
I would like to request that Mr. Lewis also send a copy of that to Director Johansson so that we have an opportunity to look through that and you're aware of what we're looking at.
Sure.
Mr. Chairman, I'd be glad to do so.
Thank you, sir.
Mr.
Senator.
Chair, thank you. Yeah, follow up on that. I would very much, I'm sure that you're watching where those dollars are going and you get a report all the time from the association. And it's documented and you're all going, okay.
Mr. Chairman.
Go ahead, Director.
And Senator Larson, yes, as you all know, we operate in what some people consider annoying, but also strict procurement rules in the state. So we're anything over $1,500 to be purchased requires a contract. Anything over $15,000 requires a competitive procurement. And so in line with that, we have statements of work, deliverables that have to be met. And again, that's an open book where we're happy. It's great to see the auditor's data. You can get a sense of, the different types of broad categories and vendors that our appropriations are going to. A lot more information behind that again, in any circumstance, we're happy to provide.
I would take, what's that? That'd be good. Yeah. I would take a second and remind folks of my initial remarks that we need to be honest and have all the cards on the table. And I absolutely appreciate your openness in doing that. And I know that will continue. Whenever we run into a situation where people were a little bit reluctant to be forthcoming, you begin to breed all kinds of conspiracy theories and all kinds of stories. So Let's get to the bottom of that. Any further? Yes, ma'am.
Mr. Chairman, on this comment, I did want to just put it into the public space as well. With JAC budget hearings coming up, every single agency is required to provide a 600 series, which is their grant and aid payments, and a 900 series, which is their contracts report. It is a standardized report that goes for every single agency. You'll get that ahead of every budget hearing. The Department of Health is a bit unique because theirs is large. And so if you do not see that on the website and you do want a copy of that, please just contact LSO. It is publicly available, too big to host on the website. But every other agency for the last, at least since I've been in budget fiscal, there is a 600 or 900 series expenditure report for the previous 2 fiscal years available in a standardized format. Thank you, Mr. Chairman.
Thank you, Ms. Martineau. Excellent as always. Further questions? Representative, do you have any final comments before you?
No, thank you, Mr. Chairman. I just want to say that the sheer volume of information we have to glean through is daunting, and we're trying to get as much information as we can and make sure that we're spending our citizens' money wisely. And thank you for the time.
Thank you, Representative. And I would say, yes, it's daunting.
Yes.
If they'd have told me how much reading was involved in this job, I'd have gone fishing. Anyway, anyone else online? Seeing none, let's take about a 10-minute break and we'll come back. And Director Johansson, you have 2 things on here, which is the federal updates. We're looking forward to maybe a little bit of an overview on the application. And then if you would like to just kind of combine that with any final comments or things that you'd like to have, then we'll do that. And then we'll have a little bit of outgoing remarks from the committee as far as what direction we're going. And I look forward to digging into this as much as we can. And that Representative Johnson's comments about the amount of data, as you well know, is staggering. And so a lot of people have been asking, well, what are you going to do? What are you looking at? We don't know yet. We're still gathering information, and we want to do this judiciously. So anyway, let's take a 10-minute break and we'll be back. Let's just say we'll be back at 10:30.
Are we muted?
Oh, man.
Good afternoon. It's so cozy. If you would come on up, Director, and give us a little bit of information about this application and anything else that you might want to add to the rest of this series.
Thank you again, Mr. Chairman, members of the subcommittee. Give you a brief overview of really the last 2 months of developing this rural health transformation application to the federal government. Kind of give you the logistics first. We submitted that plan on Tuesday of this week to the Centers for Medicare and Medicaid Services. We posted it publicly on our website, and some of you may have seen a press release from Governor Gordon advertising that as well. We posted that on Wednesday. I'll say at the outset, Mr. Chairman, it's something we really appreciate and are excited about the opportunity that the Trump administration has provided through this program. And as we talked about in previous subcommittee meetings, there were a lot of elements of H.R. 1, the Big Beautiful Bill Act, a lot of health-related elements and a lot of Medicaid-related elements. And for the most part, for the Department of Health, many of those health or Medicaid-related elements that involved federal funding, sometimes federal match reductions, restrictions, et cetera, did not apply to Wyoming for various reasons, based on our structure, how we cover, what we pay, how we have and have not implemented certain types of programs. But the reason I mention that is because we believe that the Rural Health Transformation Program, the Rural Health Transformation Fund that was created, represents a lot of upside for Wyoming, especially relative to some other states where some federal funding, and in some cases a lot of federal funding, is being extracted as a result of the bill, where in Wyoming that's not happening, and we can really leverage, we believe, this opportunity to create some lasting and sustainable change and take care of our rural health in a different way. Mr. Chairman, just to summarize, over the past 2 months, we really prioritized hearing from the public as we developed this application. CMS, the federal government, released the application guidance in mid-September, early to mid-September, with an application due date of this week. And in that time period, we really wanted to get out in person to as many rural communities as we could. Obviously, in that time frame, we couldn't hit them all, but I appreciate the gentleman sitting to my right, senior staff, Ms. Sandoval sitting behind me, and many others in the department that prioritized that. And as I mentioned to you last time, I was really thankful and also proud of the people of Wyoming that not only came out to those meetings to voice their opinions, but also participated in our virtual meetings or in our online survey. And I think what hopefully you see in the application, where some of that is summarized, to be blunt, the federal government did restrict our page limits on these applications, so not everything is in there, and we did our best to provide adequate summaries. But what you'll see, what I believe we saw from the people of Wyoming was really a reflection of funding and sustaining the basics. I was somewhat surprised, but also not surprised, because I've lived in Wyoming for quite a while now, that we didn't receive lengthy and impractical wish lists from the public. And you'll see in those priorities that we quantified and heard from people, both from the meetings and through the online survey, things like, we would like our small rural hospital to be financially sustainable, an emergency department that's there, OB or labor and delivery services that are somewhere nearby, an EMS system, an ambulance that shows up and is financially sustainable for when people call 911, that is something that we can worry less about going forward in future years. Workforce, so folks that work in the health industry, physicians, nurses, CNAs, direct care labor was a priority. And we know that that's not unique to Health and Human Services, but really across many industries in Wyoming. Do you have access to the adequate labor pool to even sustain the basics? As you go through our application and our application summary, I think you'll see some of those values reflected in the plan. But I'll also mention that part of this exercise, which was difficult in what we heard, is Governor Gordon and the Department of Health, we really had to prioritize and make some tough decisions on what this plan would reflect and what our goals and initiatives proposed to CMS would aim to do, not only over the next 5 years, which is the federal funding period, but also prioritizing sustainability over a much longer period of time. As we've talked about with this committee, we know that temporary federal funds can result in fiscal cliffs, can result in situations that a state can get in where you build something, you start something, you fund something, and when the funding runs out, you say, now what do we do? And we very much wanted to do our best to avoid that. And I hope you see that reflected not only in the items that had been selected for by the state of Wyoming in our proposal to the federal government, but also in the sustainability plan to really look at creative financing mechanisms that will result in negotiation with the federal government. We anticipate that to happen starting over the next 2 months and potentially into 2026. Of can Wyoming implement this plan not only in a truly prioritized way, focusing on really basic infrastructure and basic services that we heard from the public that are needed, but also in a way that's fiscally conservative and sustainable. Mr. Chairman, very briefly, I'll mention, won't go through the whole plan here. I know it's been posted to our website. I believe LSO shared it with you today. But just to go over some of our goals and strategy, which is a big section of the report, you'll again see that directly correlating to what we heard from the public. That was a huge priority for us, is that public input really driving a lot of the selections that we made. But I should also mention that we engaged pretty heavily with our provider groups and our provider associations, both in public meetings, but also separately to make sure that folks on the ground that are operating these services had their input given to us as well. Our first goal and strategy with this is to increase sustainable access to right-sized and coordinated rural medical care. So we go into a lot of detail of what we believe, kind of a thesis of what drives a lot of the both financial and access challenges to basic medical care in Wyoming. And it won't surprise this subcommittee because it is somewhat structural in a geography like ours and a population like ours. Many of the services or service lines that you'll see in this plan require very high fixed cost. When you consider that with Wyoming's relatively low population, it becomes a problem of scale and sustainability. How do you sustain a very high fixed cost infrastructure with low volume? And I'll use EMS as an example. And we've talked about this with multiple committees. It generally costs around $500,000 a year to operate and maintain an ambulance. Some of our rural and frontier EMS agencies might get 15, 20, 30, 40 calls per year. You're paying for that readiness. You want it available. You want it up to date. You want the folks trained. It's very expensive on the fixed cost side. With that low volume, even if you took 100% advantage of all of the payers that are out there, Medicare, which we don't run, but is a high percentage of the EMS population, generally your elderly people, Medicare, commercial insurance, Medicaid, you likely will not be able to make up that volume. And we studied EMS over the last 2 years, released a report this past summer that tried to quantify that and showed, and across Wyoming, it's probably about $30 million deficit in terms of the services that are being delivered and what can be recouped through payment per year. How does that subsidy essentially get allocated? Well, it's through volunteer labor. We've historically had a high percentage of volunteer EMS around Wyoming. It's through local funding, sometimes through the tax base, or there's an option for an EMS district that the legislature provided, and even things like local fundraising, golf tournaments, bake sales, those types of things. That's where you see that that cost gap really play out. I use that as an example, Mr. Chairman, because that can also be very similar dynamics when you think of OB care, labor and delivery, mothers being able to give birth locally or at least regionally. That's a lower volume, but very high fixed cost, high amount of training, et cetera. Emergency department is no different. Very high fixed costs. It's there 24/7. You have to have it, and you have to have providers willing to take clients in, but does not have predictable volume or client loads. So along those lines, we really wanted to try to address how can we sustainably attack that high fixed cost, low volume problem. And you see that in many of our initiatives through incentive programs for critical access hospitals, for EMS agencies, to be offered a sustainable, basically infrastructure fixed cost payment in exchange for some business model changes. Mr. Chairman, go ahead.
Quick question. You mentioned critical access hospitals. I would ask for a definition that I believe it has to do with a certain number of beds or something. Could you define that?
Mr. Chairman, I'll introduce our Deputy Franz Fuchs to answer that question.
Thank you, Mr. Chairman. Franz Fuchs, Deputy Director, Department of Health. Mr. Chairman, your question on critical access hospitals, they are restricted in a couple of ways. One is they have to have fewer than 25 inpatient beds. Many of them operate far less than that, and their occupancy is, maybe 20, 30% in many cases. There's actually a table in the application in the supplemental materials that shows our list of hospitals with their licensed beds and average occupancy. The other main restriction is they have to be the only hospital within 35 miles. So there's sort of a range restriction on that. And in exchange, the critical access hospitals, they get a much better reimbursement model from Medicare. So they're able to claim a cost-based reimbursement. So receive 101% of their allowable Medicare costs, which, as the director mentioned, because of the low volume issue, really helps them out. The bigger hospitals, which are called prospective payment system or PPS hospitals, they are on a fee schedule. They get paid prospectively. So Medicare will say, hey, this discharge should cost, X dollars, we're going to pay you X dollars, no matter what your costs actually were. And so it's a very different payment model for those larger hospitals. And so the critical access ones, they have that significant benefit. That also applies to things like ambulance. If you have the ambulance and EMS service based in that hospital, they can claim cost-based reimbursement for those Medicare allowable costs, which really helps out compared to the fee schedule on the ambulance. But they have to be the only ambulance within 35 miles. That's the catch. So, Mr. Chairman, happy to answer any follow-ups, but that hopefully gets to your question.
Probably not at this time, but I just spent some time with a state hospital, with a hospital administrator here in the state, and he was talking about the PPS or PPS fees. Yeah. That is really a strange thing to somebody from the outside to look at and say, well, this is what it is. It doesn't matter what the individual actually requires or what services, but you got somebody with cardiac arrest, so here's your chunk. If you got a large volume, that evens out, but even our PPS hospitals are smaller, so I see that as strange, but that's an aside anyway. Go ahead, Senator.
Mr. Chairman, can I get a specific example of Powell, Cody, and Lovell? They're all within really, really close. 35 might not be far enough away. Can you tell me on those? I know I maybe shouldn't be asking on just my area, but.
No, Mr. Chairman and Senator Larson, I think we have that data right up in front of us but I think it's a useful example of, how do these designations happen? Franz, go ahead.
Mr. Chairman, Senator Larson, so if you look at page 17 in the supplemental materials, which is it's table 28, kind of near the end, but there's, for example, all of those are critical access hospitals. And that some of them may have been grandfathered in when they implemented the program. So I'm not sure exactly, but they all are, none of them are PPS. Wow. Even Cody is a critical access hospital, which is one of the largest.
They're probably 30 miles.
But Cody has 25 beds. Their occupancy is fairly high. They're one of the bigger critical access hospitals in the state.
Thank you.
Thank you. Sorry to derail you on that. I like to define terms so that I have an accurate picture in my mind, so.
Mr. Chairman, absolutely, and please pepper us with questions. This has been a rapid effort, but I think resulted in a high-quality product. So again, just to summarize kind of the initiatives or goals that we selected, there's 4. We talked about a few within really the emergency care and critical access hospital and EMS type care, which really a few initiatives are subsumed within that category of really increasing sustainable access to right-sized and coordinated rural medical care. So there's some initiatives within that. Second, as I mentioned before, we want to use or propose to use these funds to build a more sustainable and durable rural workforce pipeline. A few initiatives that we, in partnership with the university, the community colleges, and even some out-of-state educational institutions that can train physicians, et cetera. We are proposing a few things within this category, really directed at increasing and sustaining rural health workforce. So again, more physicians, nurses, CNAs through a variety of mechanisms that one of which we're calling individual education support. So essentially an incentive to allow some funding or offset the funding of someone who wants to become a nurse or become a CNA or become a physician to help fund that, but then on the back end require retention in the state of Wyoming to build that pipeline over time. Secondly, again, in partnership with our educational institutions, community colleges, et cetera, to propose some grant funding for them to essentially attract workforce, especially at your younger ages, into this type of field. So think of, funding that helps offset the cost of going into high schools, training programs on the vocational side that may lead to, a CNA license and then an LPN or a registered nurse or even a physician. So really looking a bit longer term at that to fund really some educational promotion and show our younger folks that there's a career pathway within this field that can also have an added benefit that we know are rural and frontier areas that have hospital-based care, long-term care, services for folks with developmental disabilities. One of the common refrains that we hear, and I know it well because we operate 5 24/7 facilities, access to labor and being able to attract that labor, retain that labor is one of the major problems.
If I may.
Please.
In your research or in looking at this, you mentioned training physicians, nurses, CNAs. Do you have an approximate cost of what it costs to educate someone at each of those levels? And I say that because it seems to me if you focus more on some of the lower cost ones with CNAs, now that they're into the trade, so to speak, they would be more apt to move on up. So.
And Mr. Chairman, that's a very good point and a big priority of what we're trying to develop with this element, with this facet of the proposal. But it does vary, obviously, depending on the program, the school, et cetera, and the level of care of what the cost per would be. We did do some of that initial research with our educational institutions, et cetera, to be able to estimate that for the federal government. But it's a good time for me to mention that what folks will see, there's a lot of specificity within this document, but also you got to take it with broad brush strokes, because what this will look like if our application were approved and we get an allocation of funding, the implementation and the procurement of that would start, in 2026. So the devil will be in the details there on what we could finance, for example, at the CNA level or at the LPN or registered nurse level or the physician level, the psychiatrist level. So we have some of those estimates that you'll see within the plan itself that we used for the broad proposal to essentially back into cost estimates for the federal government. But they know and we know that when it comes time to implement, that's when we'll hopefully have some latitude within the state to be able to indicate to those potential recipients and also the organizations that would receive the funding, here's what this could support at this level and the kind of volume that we're looking to purchase, if that makes sense. Mr. Chairman,
Go ahead, Senator.
Mr.
Sorry.
Chairman, I'm guessing at some point they're going to delve into how this process might work. But I could ask a question then if you want me to wait. Probably.
Mr. Chairman, Senator Larson, you are welcome to ask now. I will say that there's still some unknowns. We have concepts in here. I think we have very good proposals in here that's supported by meaningful data of where we know the problems across our state are and the priorities that we selected. But it's going to be difficult to answer on the specifics of procurement and who would be the subrecipients, how many would say we want to participate. For example, the Critical Access Hospital Basic Incentive Program that you see in here, where we're trying to get our hospitals to sustain and focus on the basics that we heard from the public: emergency department, OB care, EMS, again, things that we know from our constituents. We heard resounding choruses of, we want to make sure at the very least that those things are sustained. We don't know in that incentive program, for example, how many hospitals would want to participate. And we also don't know at this point, without the federal government's decision, how much funding would we have to put into that program. So some of this will have to be evolved. It'll be relatively short term, but we're looking into early 2026 to get more meat on the bones in terms of those details.
Mr. Chairman, and we'll go to the Critical Access Hospital. I think I saw a unit was like $20 million and the proposal was $1 million maybe for a year or something. So is the idea that if they bid for one unit, would you keep that money and delve it out so they don't spend it? I guess that would be one of my worries.
Mr. Chairman, Senator Larson's a nice segue into, I'll use that as an example, where we've proposed a financing arrangement that we believe would work longer term than just in this 5-year funding period. So if a provider like that partnered with us in this program and, not going into all the details here, but happy to, if there are questions, really change some business model to focus on that basic care, sustain that basic care, provide that care. We've had several OB and labor and delivery unit closures over the last 5 years in numerous communities. So if we assume that a hospital wanted to, for example, bring that back or has it already and will sustain it, then we would offer an incentive payment every year, forever, for doing that and really getting back to what's core and critical and safety net in that community. But we really designed that around being voluntary. We don't want this to be coercive, you can't take advantage of these funds because you don't want to do a component of what's offered here. But for example, if you're providing emergency department or OB care, we would have a subset of that incentive payment that we could offer. But we really want to offer that as long as we can so that we get overall system change as opposed to, grant funding that happens over 5 years, might offset some costs on the balance sheet, but ultimately sunsets in 2032.
Mr. Chairman, thank you for that. It's good to hear.
That brings up a question from myself that maybe isn't quite appropriate at this time. Feel free to bring it up later. But I see these, like Banner Health, monster organizations coming into an area and then opening clinics and cherry picking the services they offer to the ones that are most lucrative and effectively choking out the established hospitals or, the ones that are there that are left holding the bag and paying everything else. Have you considered, is there a potential for, I guess you'd call it picking winners and losers. We're going to support you guys because you guys have been here forever, but you guys want to move in and set up this clinic. And are you able to differentiate that there, or are you able to comment on that at all?
Mr. Chairman, happy to comment. I don't know how much the comment will be worth, but I'll give it my best shot. In a way, yes. And obviously consolidation in the healthcare industry has been a common theme, especially over the last 10 to 20 years, and Wyoming's no different there. I would tie that, need economically to consolidate and have larger scale, economies of scale, et cetera, tied directly to this problem that's really one of the central thesis of this application, which is it is difficult for Wyoming to sustain the exact type of services you're talking about when we are so sparse in our population, and some of these services require such high fixed costs. I do believe that our application allows us the opportunity to address some of those fundamentals in the economics of the basics of healthcare. But I think it would be foolish of me to say that we won't continue to see in large parts of the healthcare industry going forward, whether that's, in hospital care, behavioral health care, primary care, we will still see consolidations and larger entities, operate, because there's value to that. There's value to economies of scale and being able to bring additional expertise or have telehealth support or a central hub somewhere that can support a higher level of care. But I do think in our application, quite frankly, Mr. Chairman, we have the opportunity to address some of the fundamental economic challenges that healthcare in Wyoming experiences when it comes to very high fixed cost services that right now are dependent on the volume game, and that is not sustainable.
So let me kind of flesh this out a little bit. I'm working some things in my own mind. If you look at how a hospital makes money, Medicaid, which you guys primarily deal with, that's a loser for the hospital. They're going to get maybe 40 cents on a dollar for what they would normally bill. Then you get to Medicare, which isn't you guys, that's a little closer, maybe 60 to 70% on a dollar. And so they are trying to make their margin and survive on private industry and that sort of thing. What I don't want to see happen is that we end up in a position where hospitals are more and more dependent on not just Medicaid because some of the other things have been cherry picked. And we're caught in the position of making up the difference. That's what scares me.
And Mr. Chairman, if I may, I'd love to comment on that because you hit the nail on the head with this sort of fundamental issue. And we're really trying to address that through that first category of a proposal to the federal government. And you do see that. You see small hospitals all over the country needing to try to survive through basically subsidizing costs in other parts of their balance sheet through, surgeries and elective procedures and things like that more and more are being, to your previous point, consolidated in larger systems or larger facilities. When we try to focus on the basics here, and we keep picking on hospitals, but it's not just hospitals. I think EMS is a great example as well. If the state could get into a position taking advantage of this really once in a generation opportunity on the financial side to say, we're going to do something different in paying for healthcare. We want, with some strings attached that we think are beneficial to the business models in Wyoming, we want to try to pay for or offset those high fixed costs so that dependency, that need to cross subsidize, that need to chase private pay or commercial pay type procedures at the very least minimizes to where we can articulate as a state, as our public has told us through this process and before, we want an emergency department in our rural hospital. We want, maybe not in every hospital, but somewhere nearby regionally, the ability to deliver babies. We want a sustainable but reasonably managed and efficient EMS and ambulance system. And I think where you see where we've prioritized is directly centered, Mr. Chairman, around the comments you just made of trying to fundamentally transform that dynamic that I think has become somewhat unsustainable for Wyoming. Mr. Chairman, the third category that we designed some proposals around is really kind of in the Make America Healthy Again lens of what the federal government had offered in in this application guidance, and that's improving metabolic, cardiovascular, and behavioral health outcomes through a variety of initiatives, but looking to support, healthier lifestyles in our population. Things like exercise and diet, but again, not in a prescriptive or coercive way, but really opportunities for organizations around the state to have some time-limited one-time grant funding to support exercise or outdoor recreational activities, which we are so rich in this state, to try to improve some of the health outcomes that we see. And we quantified and prioritized those around some of the issues that or conditions that you see articulated in the plan that our data show this is where Wyoming is maybe higher than average in terms of that disease burden. So we've designed some key programming around basically improving the health of Wyoming residents through their nutrition and exercise. And finally, Mr. Chairman, our fourth category is around technology. We know in Wyoming, with our large geography and small population, the last 10 years has provided a lot of opportunity and value when it comes to technology, telehealth, telemedicine, telepsychiatry, those types of things that are a little bit easier to scale when you can leverage technology. But the fundamental challenge that we have, and as a card-carrying bureaucrat, I'll be the first to admit that we don't know all the answers, and we didn't want to be in a position to decide and pick winners and losers that we like this technology platform or this particular AI-driven solution to some sort of, healthcare service. And instead, one of the initiatives that I'm excited about in this plan is what we're calling the Technology Adoption Challenge. There's a lot of technology out there. There's a lot of tech companies. There's a lot of products. And we hear from our providers, our communities, our residents, we should be doing this. We should be using this. So we want to leverage that interest to offer funding that requires a few things. If there are more than 2 providers or more than 2 organizations or more than 2 communities, could be in a city, in a town, in a region, in a county, that have agreed they would like to implement a technology platform or a product, and they bring some skin in the game. Maybe there's some financing they have, but they can't afford the full product. We could use these funds to offer that to do 2 things. One, get that started. And again, I think having a critical mass where we would look at those applications and say, hey, we've got 12 providers around the state that want to implement this. They have some funding available. We can provide, that seed funding and that 5 years of operational funding. And then second thing, you need to have a sustainability plan. If you like that, if it works, et cetera, then it's, you would commit to that financing. And again, devil's in the details there if this gets approved, to go start those requests for applications or procurements. But I think the concept itself is really less about the state and the Department of Health picking the winners and losers in technology and really having more of a bottom-up grassroots. This is what these particular hospitals or facilities or communities or organizations are already interested and would, adopt on their own and would finance it on their own. This would just help get them started. And the last thing I'll mention, those are kind of the 4 critical areas, the big buckets of goals and initiatives that we have in this proposal. The last item that's worth mentioning is there were a few elements of the federal guidance that were called state policy actions. And these were various elements that could warrant more favorable scoring for the state from the federal government's perspective if the state committed to certain policy actions. One of which you'll be very aware of, which are these SNAP waivers. Limiting SNAP benefits to nutritious food, et cetera, something the legislature has discussed the past 2 years. And so we worked with Department of Family Services. You probably saw that is already in process in terms of applying for a waiver. So we included that in our application because if approved, we could likely, with these funds, help pay for or offset the cost of implementing a waiver like that, both on the technology side, on the state Department of Family Services evaluation side, et cetera. Secondly, there's a state policy action around the presidential physical fitness program, which I participated in when I was a child. It's being reinvigorated by this administration, and we worked with the Department of Education, who also committed to this will be a requirement in the state for our education system to participate in that, physical fitness type program, and we can get some more favorable scoring in this application and potentially some additional funding. Mr. Chairman, I wanted to close with a section that I would direct your attention to in the plan, which is section 4, our proposed initiatives, but also our use of funds and the sustainability plan with those funds. And pardon me, that's section 8, starts on page 51. We have some discussion there on kind of the principles that we used, many of which we heard from the public through the engagement process. But also, as we've been talking about, the lessons learned from previous rounds of federal funding and trying to avoid these fiscal cliffs. We've proposed a sustainability plan that we think is creative, that was very pleased to work with the governor and his staff, the treasurer and his staff on coming up with this concept to be more conservative with these funds and see if we could stretch them over a longer period of time than 5 years. And without going into too much detail, because we will, over the next 2 months, likely be in active negotiations with the federal government on this, we want to use what I think Wyoming is very skilled at, and that is not only saving money, but generating additional revenue over time, where we can, in an irrevocable and inviolate way within these priority areas, potentially sustain this program for the long term, not for 5 years, but really have sustainable change, transformation, which the federal government wants over a long period of time. So we're calling that the Rural Health Transformation Perpetuity. And again, I think I can't speak much to the favorability or not of that when it comes to the federal government, but we are very excited about the opportunity to discuss that and really have I think a unique Wyoming designed solution to create lasting change and lasting sustainable healthcare infrastructure in the state. Mr. Chairman, I'll just close my comments, obviously see if my colleagues have anything to add, but also just reiterate what I mentioned before. This was a rapid cycle development, but the public participated. We had over 1,300 responses to the online survey. We did our best to tease out in that survey if you're a Wyoming resident, a healthcare provider, or a Wyoming resident who's just a member of the public. And I think as best we could, we really tried to garner true feedback from the public. And I'm proud of what we received. And hopefully, as you peruse that plan and as we continue to update our committees in the weeks and months to follow of how this process goes with the federal government, we're really excited about the opportunity to take full advantage of what the administration has offered to rural and frontier states, of which Wyoming is one of the most rural and frontier. With that, Mr. Chairman, happy to answer any questions or defer to my colleagues.
Question.
Thank you, Mr. Chairman. I'm wondering if there's like an equivalent of an Oscar for best grant application that we could submit for you guys, because this is so cool. This is so incredible to see our public's feedback in a document like this. And it's such a visionary approach to leveraging these funds. So just thank you guys very much for your work on this. Random, probably devils in the details, but 2 questions. In terms of the promotion of exercise, is there an opportunity to partner with state parks and outdoor rec to do some sort of fun challenge? And then in terms of technology, is that something our ETS department will be used for their advisory or expertise skills to help in that area?
Mr. Chairman, Representative Sherwood, general yes on both. Again, as you mentioned, devil's in the details. It's hard to predict the demand for some of these things until we actually put them out there, if we're approved and if we have, federal funding allocated towards those initiatives. But yes, I could see both very much happening.
When I joined the Army, I specifically joined as a wheel vehicle mechanic. Hiking is right out. Go ahead.
Mr. Chairman, thank you. I looked through it last night and I was pretty excited. I'd hope the public's excited too. I hope our hospitals, I hope they're looked at it. I think it came out today, hopefully for them. So yeah, good job.
Mr. Chairman, Senator Larson, thank you for that comment. I'll just mention, and as I said before, this was an exercise in prioritization, and that's tough to do. So when you talk to your constituents, your providers, et cetera, there are things that they won't see in here that they wanted to see. I'm optimistic and hopeful that generally speaking, through the engagement that we had, we'll have general support, and we got numerous letters of support from those organizations for this application. But absolutely, this was an exercise in prioritizing, and we really, similar to the department's now 2-year-old strategic plan, we've really tried to prioritize and neck down to what's critical, what's core, what's safety net, and I hope you see those principles reflected in this plan as well.
Mr. Chairman, just a comment. Yeah, I took the survey and I think you picked out a lot of the things I wanted. So I must have swayed them.
And just to be clear, Mr. Chairman, we did not ask for demographics or names, so we did not play favorite with Senator Larson to say, let's make sure we get all of his initiatives in there.
I didn't submit one. Nobody ever listens to me anyway. I don't think I had any questions myself. So either of you gentlemen care to weigh in and color this a little bit?
Friends, Jesse.
Mr. Chairman, we're just here for any questions you might have on this.
Thank you. In terms of the timeline, in terms of some of those suggestions for legislative priorities, I know some of them are called out as potential interim topics, but has this been presented to Labor Health, or like what are the next steps in terms of some of those legislative areas we need to address?
Mr. Chairman, Representative Sherwood, it's a really good question. So we presented some very initial concepts to Labor Health at their last meeting, which was prior, I was going to say long before, but it was like 3 weeks before this application was due. There may be some legislative needs depending on the federal government's review of the application, and we're more than happy both with appropriations, with Labor Health, judiciary potentially, to bring those items back during the session or queued up for interim topics. I'm relatively confident that with the state policy actions, there's kind of a scale of states that already had a SNAP waiver in the system. They will score higher on that than we will, which is we are in the process of submitting that. So that's kind of just the reality. It is what it is. But in terms of potential legislative action, I think we'll know far more in January and going into February of when we've had interaction, discussion, negotiations, hopefully approvals with the federal government. For example, on the financing mechanisms that we've proposed, likely a need with the Appropriations Committee in the legislature to have that discussion on what types of accounts or instruments would need to be set up so that we can not only take full advantage of the funding, but set Wyoming up for sustainable long-term success with that. So we have those, we'll have those concepts ready to go. Right now, we're a little hesitant to put that out there because the federal government just received our application on Tuesday, and we want to make sure that we leave some time for those discussions and negotiations.
All right, thank you for that. I guess the last thing on the agenda was any final comments from the Department of Health. And so the floor is yours.
Mr. Chairman, thank you. I'll be brief. You've heard a lot from me over 3 meetings where we spent hours and hours and hours in the doldrums of the Department of Health's budget and bureaucracy. So mostly wanted to thank the subcommittee for its time, but more importantly for your interest and willingness to dive into some of these details. As you probably feel, it's hard not to feel like we just scratched the surface because there's just a lot of information, a lot of data, and a lot of history. To that point, and kind of dovetailing off of earlier this morning's discussion, I think it's worth lining out some of the history that we're very interested in the Department of Health, but folks often don't know about. And if you go back in time, the Department of Health is actually a very recent creation by the legislature. Department of Health as it exists right now is actually a function of something that happened in the 1990s. Before that, and going back to long ago in the earlier part of the 20th century, what you know is the Department of Health was then called the Board of Charities and Reform. You also had all 5 facilities, the State Hospital, Life Resource Center, Veterans Home, Pioneer Home, and Retirement Center. Those were all separate entities and separate budgets in previous decades. In the same way, the Board of Public Health, which turned into the Department of Public Health, was also not part of what is now the Department of Health. And similarly, up until the early 90s, our aging division was actually the aging department. And so coalescing in the early 1990s is where you see a lot of these things, these different functions of the state from the 20th century kind of slammed together into one larger department, which you now know as the Department of Health. So when you see those budgets enter going into the 90s, you will see this pretty rapid growth in the budget because you essentially had 4 agencies and 5 direct care facilities being combined into one department. In addition to that, Mr. Chairman and members of the subcommittee, you can absolutely see it in the data that LSO makes available in their very handy budget tools. Also, this public data from the state auditor's office, et cetera. In the late 1990s and in the early 2000s, a lot changed, especially in the Medicaid landscape of what was available to states to cover. Things like home and community-based waivers for the developmentally and intellectually disabled, which the Appropriations Committee has really prioritized as a topic this interim. That's also relatively new. And the state of Wyoming and most, in fact, all other states elected to take advantage of those optional services. So in the late 90s and bleeding into the early 2000s, you see a very exponential growth in Department of Health's budget because the state was authorizing not only those optional services for folks with DD or long-term care as a alternative to nursing home or institutional care, but also optional coverage groups like pregnant women are also relatively new in the Medicaid landscape. So I thought it would be helpful to offer that historical perspective about the Department of Health's budget. And absolutely, we are a super agency. You know, we have a lot of functions, and that has grown over the years, but largely a function of reorganization in the state to create what is now the Department of Health. And since that time period, late 90s, early 2000s, you can really see the legislative decision-making in some of those areas of growth when it comes to rate increases that the legislature has authorized, increased reimbursement rates, rebasings, et cetera, that really do center around those higher scale coverages and programs, not just in Medicaid, but also in community mental health. That budget, I think it was in the early 2000s, was effectively doubled from one biennium to the next, creating, in our behavioral health division, 4 pretty large units that fund our community mental health and substance use centers. So I think that historical perspective is helpful in going back and tracing, the roots of where some of these costs and where some of these coverages come from. But Mr. Chairman, in closing, I would again just thank the committee and also your diving into and questions around how the department manages its program's performance, how we develop budget requests, the various things we look at to monitor and mitigate fraud, waste, and abuse through our program integrity functions. I think it's just been a really healthy discussion, and I know you all are forced to make tough decisions. And when those tough decisions happen, we really want to be an agency that is here to be a neutral arbiter, bring you the best information that we can on the impacts of your decision, whether you're looking to increase things, decrease things, or maintain and sustain certain elements of the department. So again, it's been a slog for us preparing all the information that we thought would be helpful to you, but I know it's also overwhelming and inundating with what you have and the gravity of decisions that you may have in front of you. With that, Mr. Chairman, happy to answer any final questions.
Go ahead, Chair.
Mr. Chairman, when he mentioned fraud, waste, and whatever abuse, rang a bell, I guess. I had someone comment that not too long ago, you had staff out further out in the state, and I heard comments that maybe that hasn't helped with the fraud abuse stuff, that maybe you're too centralized and don't. So I just, maybe a comment on that and yeah.
Mr. Chairman, Senator Larson, happy to comment and ask Mr. Springer to provide some color commentary as well. As we talked about in our last meeting, we did bring a lot of our eligibility functions in Medicaid into in-house, centralized outside of field offices around the state. The actual reason for that was to minimize human error in eligibility determinations that we saw were growing over time, to implement a more rules-based system that we went into great detail in that in your last meeting, so I won't belabor the point. But I think it's well taken, because what you can gain in efficiency and accuracy of eligibility through good system work, modern technology, et cetera, most of which is the responsibility and great achievements of Mr. Springer and his team here. We are a leading state when it comes to Medicaid technology, but there's pros and cons to everything. And I think folks interacting with systems and call centers versus a local office, you lose some face-to-face customer service, things that we try to build back into our programming, so we have that high touch. But that's absolutely the genesis of bringing those things in-house and reducing our overall field office presence in Medicaid. Jesse?
Chairman Pendergraph, Senator Larson, we did see pretty sizable drops of enrollment when we implemented the rules-based eligibility system and did the centralization, mainly from just enforcing the rules more standardized way. I do think some of the identity verification where putting human eyes on a person was helpful is being supplemented now by a lot of the technology matches we have, where we say we can see this person in the Department of Labor, we can see this person in Vital Statistics, we can see this person in Social Security Administration, and we have an exact match or it doesn't match. We can, we have a lot of data matches now, Department of Homeland Security. So we do have very good verification. At least the Trump administration has started these verification reports. So we've received 2 so far, and I'm very happy with how we're doing on those. So we had a citizenship legally residing verification that came through, and we were sent a few hundred people, and our error rate on that was far less than 1%. I think we had 1 error. So out of 200. And so, we are feeling very good through those verifications, that we are having high data quality, that our processes are good. We're looking at those to say, how do we do these ourselves more often, so that it's not the federal government telling us something. But we do have field offices for our home and community-based provider side. And I've had the opportunity to interact with that staff, and I love having staff out in the communities. So we have staff in Evanston, we have staff in Lander, we have staff in Buffalo, we have staff in Casper. That's, I think, a huge strength. And so something, we will be exploring is can we make better use of those field offices? Should we have different type of field offices, but not necessarily having a huge portion of our eligibility staff outstationed. But I do think, people benefit. Maybe this is even workshops or something from, hey, I've just been really stuck in my community. I can't make it to Cheyenne, but I really need a human being to sit with me. They're just clients that need that level of support. So, we're trying to figure out how to make that happen.
Mr. Chairman, thank you. Thank you for that response. I guess your assurance that if someone comes forward that it's confidential and that sort of thing is very important to a lot of people, and you take it seriously, I'm sure. And anybody that calls the Cheyenne, I guess, is going to get a response, hopefully, if they
Mr.
feel
Chairman.
somebody's doing something.
Mr. Chairman, Senator Larson, absolutely. There is a variety of pathways to make referrals on even suspected fraud, waste, abuse. And I know we gave a high-level overview of our program integrity function in Medicaid in your last meeting, but that can be from individual members of the public, that can be from employees of provider organizations, that can be from beneficiaries, that can be from family members, both on the client side and the provider side when something is suspected. And as we also presented on very briefly at your last meeting, the benefit of us modernizing our technology systems, we have more tools now to have fraud models that we can put into our claims data and look at, do we see concerning trends where before we might be looking at, hey, this particular rate or service is being exponential growth in utilization over the last 2 years. We need to look at that. And that absolutely happened before. Now we have some additional tools on the technology side to maybe put those red flags up a bit earlier so that we can, as we talked about last time, we really want to be less of a gotcha state when there might be suspected overutilization that could be abuse, could be fraud, but might be a documentation error, might be a claim submission error that we can help train our providers and our members of, let's make sure we're not getting to that point that there's a big recovery on the back end. But absolutely those, I would give you my assurance. I know Jesse would agree with me that we can always improve and we're always looking to do that. That's what our health stat process and just the general culture of the department is all about. So I'm not suggesting that we're perfect, but I think especially over the last 10 years, we're in a very good place with making sure we have a handle on fraud, waste, and abuse in our Department of Health and in our Medicaid program.
Mr. Chairman, and I would guess that's on your webpage and it's pretty visible and there's an easy way to find a connection.
Chairman Pendergraph, Senator Larson, it's pretty catchy. Report Medicaid fraud. Big red button. We have a phone line. We have an electronic way to report it. So I think it's pretty effective. We do get leads through that mechanism, usually provider fraud, but also I see something that I think is suspicious for a client. People do report those and we investigate them. And we collaborate closely with Department of Family Services. They do SNAP investigations as well and other type of benefit type fraud. So we're always working with them. If they find something, they refer to us. If we find something, we refer to them.
Thank you guys so much. I don't underestimate the amount of time and effort that it takes away from your normal busy job to come here and do this with us. I promise you we're not going to squander that. We'll make you pay for it. I would like to offer my colleagues one last opportunity for some comments. And I will have some comments myself at the close and kind of let the public know where we go from here.
Mr. Chairman, thank you. Yeah, lots of information here. And hopefully my chair's taking care of all that. No. I guess my biggest concern with us doing a whole lot until we see what the proposed budget is. And so November, 17 or something, we might be seeing something. So I guess I'd be asking my chairman if we're going to meet after that. I think that's vital.
Duly noted. We'll discuss that momentarily.
Thank you, Mr. Chairman. I guess just a general comment that through this process, I have learned that you are a lean and efficient organization. I absolutely adore that you're constantly looking for ways to improve. I think that is a sign of true public service and not just business as usual, right? But there's always an opportunity to innovate or to pivot or to improve. And that's very much apparent in your health stats. So I just want the general public to know that I think we have the best Department of Health in all of the United States. maybe even broader than that. And I know that the general public doesn't always understand everything that you do because as you described in, this history of combining all of these services, you are a super agency, but you're super good at what you do as well. As a historian, I do appreciate that, like, if we look at each of the units in your budget and take those out, right? Those used to be standalone things. I think that's a really good perspective headed into this. But with the survey and the public comment that helped develop this rural health transformation, what I hear our public saying is they want our basic services provided and they want stability to know that those services are going to be there for them. So I just wanted to say thank you for the work that you do. Thank you for the time you spent both educating us and at the same time writing your Oscar-winning nomination for rural healthcare funding. And I hope that the public has gotten just a little glimpse into the work that you do to provide our citizens with healthy, happy lives. Thank you.
Thank you, Representative. I'm going to buy you some pom-poms. This has been a fascinating experience, and I would say to the public, this is really where it begins. What we have done thus far is a lot of fact-finding, a lot of bringing ourselves up to speed. To say that we are actually up to speed with all of this would be probably a stretch. But I think it gives us a better concept going forward. And so I kind of wanted to talk a little bit about how we got here. You'll recall that at an appropriations meeting, the department came to us asking for more money for the DD waivers. Would you care to correct me, sir?
Mr. Chairman, thank you for the opportunity. We did not request DD waiver funding in our last budget. That was something that the legislature took on as an interim topic. We report on that, every 3 years, I believe we're required to do a rebasing. But just to clarify, that was not requested in our most recent budget. But absolutely, the interim topic developed was about expiring funding that was happening in those programs.
So thank you for the clarification there. That's quite fair. Wyoming doesn't have a professional football team. And there are two reasons for that. The first one, and maybe the most important one, is that if Wyoming had one, Colorado would want one as well. The second one is we're 587,000 people. And we don't have enough people to support that industry. And that to me is a little bit of a reality check. And I said at the beginning, sometimes we have to take emotion out of it. We look at what the Department of Health is doing, and you guys are be commended for your dedication to this, for what you do, and your focus is on the Department of Health and what we can do. And you hear the testimony from people and you realize what it does for people, at least on the surface. And nobody wants to say no to nothing. Hard to say no. But from where we sit as appropriators, I know I myself am liaison with probably a dozen different agencies, some of them fairly large. And I hear the same thing from all of them is, man, it's really hard to staff. We can't afford to pay people a going rate. We're struggling. And when I look at that all across the state, virtually every agency that I talk to, I begin to feel like we're spread a little thin. We're trying to do too many things. We're trying to sponsor a professional football team and we don't have the horses for it. And so I really appreciate with the strategic plan that you guys put out and with this rural health transformation, the concept of sustainability. And that's what I seek. And that's what I believe the rest of of our committee and the leadership there is seeking is to insulate us as much as possible from the boom and the bust and the having to, we got money, we just got a good Craig report, so let's go out and we're not afraid to spend that money. And we expand a little bit and it grows and we take on a new program and we've added new programs over the last few years and just keep growing the thing, which puts more burden on. And then the worst part about it is somebody gets used to the idea that those benefits are there and they become dependent upon those benefits. And then we have a downturn, something happens like we had in 2017 and in 2021, and we've got to take those away. I don't want that. I would rather pick a size of government, and I'm not just talking about the Department of Health, but I'm talking about all the way across the spectrum. Let's pick a size that is affordable. Let's live within our means so that when the good times are there, we don't overextend ourselves. And when the bad times come, we don't have to turn around and say, well, I guess we're going to have to do without. So I'm interested in sustainability, in staying even. I was particularly sensitive to former Representative Sweeney's comments about, just holding itself because of the effects of inflation and other things. That's a reduction. So the other proposal that we make is basically twofold. One of them is to start thinking more along the lines of a zero-based budget where we start and prioritize, as you guys have been doing, and prioritize the most important things first. We have to do these. We have to do these. These are mandated. Let's do those. But not only let's do them, but let's do them well. Let's pay the CNAs what they need to be paid. And instead of having 35 programs, maybe we can only afford 15. Nobody wants to take away a program. But by the same token, if you're spread so thin that you're not doing any of them well, there's an expression about half a donkey. We need to avoid that. And we have finite resources. So we'll be looking, the committee will be looking at, and we will be meeting with you guys, seeking more information, getting your input. What are the essential programs? And I don't know that I have an accurate list yet about what are federally mandated, what do we have to have? And then we have to look at, okay, what happens if we did cross the line and cut that, what programs might be able to be scaled back a bit and so that we don't yank it out from the most deserving. But we bear in mind continually what is the proper role of government. I mean, obviously it's nice to be able to give away things, but that's not always the best thing for people. So we need to look at that. I also have been getting some information on what some other states have been doing on fraud, waste, and abuse programs that they have. Obviously, no system is perfect. I think ours is pretty good. I don't know that I would say it's the best in the world because I haven't examined the others. But I am digging up some information on ways that maybe the legislature can provide you with a framework that helps you prevent, not just on the suppliers or on the people that do the work, but on the people that are receiving the benefits. What really irritates me is you have people that are, to put it mildly, have a tendency or a desire to game the system. And what they are doing effectively is stealing money from people who actually are deserving. And so the better opportunity we have to filter those out, the better. We do care about, and I think we've all three made that very clear, we care very much about the people that we're out to help, and we want to be a help. But we want to do it as efficiently as possible, and then as appropriators, we've got to look at the big picture. UW comes to us with they want another 40 million. this all got to go through the governor first, which leads me to my last comment. We really, before we can go a whole lot farther, we need to see what comes off the governor's desk, and that's not due until the 17th. We had a meeting scheduled for the 14th. I think that we would be premature in trying to do that. We need a chance to look at what the budget comes out, and then perhaps have a study session after that. There will probably, I say probably, there will most certainly be discussions between all of us back and forth, filling in the gaps as we begin to try to look at what we're doing. Anything that I propose, I want to run by you because you know things that I don't know, and you're going to say, if you do that, I always liken it to a big pile of pickup sticks. You know, if you move that stick, these are going to fall. Everything's interrelated. So as I've said many times, we want to do this as cautiously, as judiciously, and as humanely as possible. But we do seek to take Wyoming as a whole, including all these agencies, back to pre-COVID spending levels where we feel we can manage, and then tie that, any future growth, to the rate of inflation and the population growth. So that's our goal. And thank you guys for being willing to help. Thanks for fighting back when necessary. And I appreciate all that you have done. I believe that we have worn this topic out and everybody's ready for lunch. And with that, there is nothing else.